Good morning, one and all. Good morning, one and all. I'm Dr. Sangeeta. Today, on behalf of Medicover, I heartily welcome you all to the Neonatal Symposium. Before introducing our speakers, I would like to take this opportunity to thank our nursing team for their tireless efforts, especially in these unprecedented times of COVID pandemic. They work tirelessly day and night to take care of all the needs and requirements of the patients without a frown on their face. We must applaud and salute for their efforts. You all are the backbone to the healthcare industry. Thank you once again for the selfless services being offered. Now, I would like to brief the objective of this symposium. We all know that healthcare world is ever changing, constantly evolving through advancements in technology and knowledge. New drugs coming into play, new ways of administrations. Healthcare provider, it is our responsibility to upgrade ourselves, upgrade our teams, our nursing units, nursing teams to provide better quality care to the patients. With growing patient expectations and needs, the role of a nurse is being evolved. These kind of symposiums, workshops, and continuous education programs will empower them, will help them to understand the recent advancements, strengthen their basics. By saying this, allow me to flip the coin. The other side of the coin is constant increase in mortality rate due to medical negligence. If we see the literature on the medical negligence, according to WHO survey, more than 138 million patients are harmed by the healthcare professionals. The major contribution is from nursing, reason being lack of coordination and awareness. According to another study done by Harvard University, there are 5.2 million people are dying due to human medical errors per year. In 1999, mortality rate was about 98,000. This number has been almost doubled to 180,000 in a decade. According to recent studies, medical negligence is the third leading cause for the deaths. Unfortunately, 52% of these adverse effects are preventable. Empowering our nursing team with these kind of symposiums and workshops would fill the lacunae. Without further delays, I would like to introduce our first speaker, Dr. Janardhan Reddy. He's a leading pediatrician and intensivist in Women and Child Medicover at Madhapur. Over to you, sir.
Hi, good morning to all. I'm Dr. Janardhan Reddy, consultant pediatrician, Medicover Women and Child Hospital, High-Tech City, Madhapur. So I hope all of you are doing good in this pandemic time. And thank you for joining this education series for the nursing team. So my topic is basically seizures. So seizures is one of the most common neurological emergency in pediatric ER, emergency room and the pediatric ICUs. So I want to discuss with the nursing team, discuss and enlighten the nursing team about seizures, basically an introduction and followed by goals of treatment and how to stabilize the patient and medication, how to give the medication and choosing the right choice of anti-epileptic and to prevent unwanted errors in the seizures management. So regarding seizures, it is most common neurological emergency in pediatric emergencies. and where we can see regularly during night time in ER, our cases will be there in our ER. So by definition, seizures is a transient occurrence of signs and symptoms resulting from abnormal, excessive or synchronous neuronal activity in the brain. So we can, in simple terms, like abnormal electrical discharge in the brain, which interrupts the normal activity of the brain. So, and epilepsy. This is seizures and epilepsy. So many people they are, and interchangeably we are using these two words. But epilepsy is defined as greater than two unprovoked seizures in time frame greater than 24 hours. That means two seizure episodes with a gap of more than 24 hours. We can call it as epilepsy. And status epilepticus. So classically definition is if seizure activity persisting more than 30 minutes, then we'll call it a status epilepticus. But now because of recent operational definition, we now definition is like continuous seizure activity for at least 5 minutes or two or more seizures in between without regaining consciousness. And one more definition is like refractory seizures, status epilepticus lasting greater than 30 minutes despite optimal therapy with first and second line anti-epileptic drugs. That means, so after giving medication, still seizures persisting more than 30 minutes, then we'll call it as refractory seizures. So, what are the way to treat seizures early? Because prolonged seizures are risk of neuronal injury, hypoxia and neuronal injury, and cardiorespiratory compromise. So, if neuronal injury occurs, then again seizures, prolonged seizures will be there. And longer the seizure persists, greater the risk of drug refractoriness. That means if seizures without intervention, early intervention, seizures can prolonged seizures will be there. So then increased drug refractoriness. And if you don't treat seizures, there will be 3% mortality. So this is one of the most common medical emergency in pediatric emergency room. So mainly regarding this topic is for sisters, to enlighten the sisters. So here our focus is mainly educate the sisters. So like we need to keep the goals for treatment of seizures, like to stabilize the patient. Initial stabilization is very important, and correct the correctness. That means we need to check the temperature, hypoglycemia, and electrolytes, and prompt control of seizures, and prevent recurrence, and prevent complications. These are the common errors we'll do in seizure management, like inadequate oxygenation and ventilation. If you don't give adequate ventilation to the actively seizing child, then there will be hemodynamic compromise and hypoxia and neuronal injury will be there. And one more problem where we'll face in the ER is difficult venous access, especially in actively seizing child, and that leads to delay in drug administration. So this is one important problem where we'll face in ER, and inadequate dosing of anti-epileptic medication. So we need to know what is the exact doses for each drug and how to administer, and duration of the administration also we should know. And failure of vigorous IV therapy early in seizure, thereby allowing progression to refractory seizures. That means if you don't give early intervention with early medication, then there will be refractoriness to drugs will be increased because of internalization of GABA A receptors. So first, as we discussed, stabilization. Stabilization phase is if any actively seizing child present to ER, so we should stabilize the patient within 5 minutes. So like when initial stabilization, like airway, breathing, circulation, and uh, like investigations and evaluation. This is the important in any stabilization. I mean, any case, sick case. So like airway and breathing. So if you if actively seizing child, we need to keep the child in left lateral position to prevent aspiration. So one is position. Then to maintain the airway patency, we chin lift. To maintain the patency, we need to chin lift, and again continuous oral suction with gentle suction with anchor catheter, and NG tube to prevent to prevent emesis and the lung aspirations. And we need to start supplemental oxygen with better to start with NRM, non-rebreathing mask. It will give at least some kind of beat. So it gives 100% oxygen. So it is always better to give NRM with NRM supplementation of oxygen with NRM. And if you don't, if there is inadequate airway maintenance and ventilation, then we can see hypoxia. That means saturation less than 90%, and then cyanosis, then stridor or noisy breathing, then there will be hypotension. So to maintain airway patency, we need to do gentle suction. If still, unable to maintain the airway patency and hypoxia persists, then we need to do bag and mask ventilation and clear the secretions. Still, if we are unable to maintain the saturation and there is a bradypnea because of prolonged seizure, we need to go for intubation. So intubation, as advised by duty pediatrician in the emergency ward. So we need to load the emergency medication. So this is the stabilization phase. We need to complete within 0 to 5 minutes. And if possible, better to get 2 IV access or else at least 1 IV access to give medication. And we need to collect some blood samples for things like blood, CBP, CRP, then electrolytes. And we need to check hypoglycemia if there is any hypoglycemia. And we need to correct the hypoglycemia if hypoglycemia present. And we need to check the temperature. If there is any pyrexia, then better to give IV paracetamol to control the fever. So again, I am telling, one is positioning is important, then maintain the airway patency, then regular suction, then NG tube for the NG tube for prevent lung aspiration, and IV access for early administration of IV medication. This is the position where this picture shows. We need to keep the child in lateral position to prevent aspiration.
మెడికల్ ఉమెన్ అండ్ చైల్డ్ నేను రావాలంది అంది. సర్లే కావాలి మనం ఫీల్ చేయాలని నేను ఓకే అని. కవిత మేడం, రవీంద్ర రెడ్డి సార్ చెప్పాక
So next initial stabilization phase followed by medication. So medication, like we need to use generally benzodiazepines is the first preference of choice. Medication of choice like midazolam, lorazepam. So if IV access is there, better to go for lorazepam. We need to give 0.1 mg per kg over 1 to 2 minutes to terminate the seizure. If IV access is not there, then no need to be panic. We need to give midazolam by IM like dose of 0.2 mg per kg, or in the intranasal also we can give 0.2 mg per kg. Like for example, if you take 10 kg child, we can give around 1 mg intranasal dose. So one puff contains 0.5 mg. So 2 puffs is enough. So and buccal we can give 0.2 to 0.5 mg per kg, and maximum dose for midazolam is 10 mg. If there is IV access, we can give midazolam also, like 0.1 mg per kg, and maximum dose will be 5 mg. For lorazepam, maximum dose will be 5 mg. Even diazepam also we can use 0.1 mg to 0.2 mg per kg. Rectal suppository we can give. If still seizures persist after one dose of lorazepam or midazolam, we can give one more dose to terminate the seizure within 10 minutes. Within 10 minutes of onset of seizure. Even if still seizures persist more than 10 minutes after giving 2 doses of lorazepam or midazolam, we can go for a second line antiepileptic like fosphenytoin. Fosphenytoin we can load 30 mg per kg with maximum dose of 1.5 gram, and with infusion rate around 3 mg per kg per minute. That means around 10 to 15 minutes we can give. Rather than using phenytoin, fosphenytoin has few advantages like less complications like arrhythmias and less extravasation. So phenytoin has more side effects like extravasation and cardiac arrhythmias. So phenytoin administration we can give over 20 minutes. So we need to know that any anti-epileptic, second line anti-epileptic, we can give over 20 minutes to prevent complications like cardiac arrhythmias and myocardial depression and this extravasation. And one more second line anti-epileptic is valproic acid. We can give 20 mg per kg with maximum dose of 3 grams, and infusion will be around 20 minutes. And other anti-epileptic, second line anti-epileptic is phenobarbital, 20 mg per kg, and this one also we can give over 20 minutes. So if phenobarbital rapid and administration can cause respiratory depression, hypotension. So we need to give over 20 minutes to prevent these complications. So for second line antiepileptics, one thing we need to underline here is we need to give like infusion rather than bolus, and infusion should be around 20 minutes, and ideally around 20 minutes. If you don't know the minute calculation rate, better to give around 20 minutes. If still seizures persist more than 20 minutes, 30 minutes, then we call it as refractory seizures. And refractory seizures, we can go for midazolam infusion or phenobarbital infusion or thiopentol infusion. Based on doctor's prescription, you can give midazolam or phenobarbital or thiopentol. This is the routes of administration for midazolam. One picture showing IM injection of midazolam. One is intranasal administration of midazolam. One is buccal administration of midazolam. So if you don't get IV access, don't be panicked. We can give midazolam in other ways like IM or intranasal or buccal. If you don't give medication, prolonged seizure can cause bradycardia, hypertension followed by hypotension, arrhythmias, and cardiac failure. And respiratory wise, it causes irregular breathing followed by apnea or aspiration pneumonia. If there is renal, there is a oliguria, tubular necrosis, and myoglobinuria, and metabolic complications like hyperglycemia, hypoglycemia, hyperkalemia, hyponatremia, metabolic acidosis, and lactic acidosis. So was the episode of an epileptic seizure. So actually we need to know that there are seizure mimics where we need to know whether it is a seizure or not. Like breath holding spell, syncope, and psychiatric disturbances, night terrors, migraine, transient ischemic attacks, prolonged QT, GERD, pseudo seizures. These are the common differential diagnosis for seizure event. In breath holding spell, there is a child will cry few seconds followed by breath hold and unresponsiveness. We'll see in breath holding spell. Syncopal attack, there will be sudden loss of posture control, and psychiatric disturbance where patient activity mimics seizure, and migraine, severe migraine can present like seizure, and prolonged QT causes syncopal attack and mimic seizure, and severe GRD where severe gastroesophageal reflux can cause tonic posturing and mimics like seizure, and pseudo seizure. This is voluntary activity mimics seizure. And there are seizure types called generalized seizures and partial seizure. Generalized seizure, when there will be tonic seizures and clonic seizures, tonic-clonic seizures, myoclonic seizures, atonic seizures, and absent seizures. This is tonic posturing of actively seizing child. This is the clonic phase of actively seizing child. And partial seizures like motor, sensory, autonomic, and psychic. And one more thing, complex partial seizures. There will be impairment of consciousness in complex partial seizures. And partial seizures with secondary generalization, we can see other type of seizure. So these are the causes of seizure. One is infection. Infection, child generally they will have history of fever for 2 to 3 days followed by seizures. So in meningitis cases and head trauma, one common neurological emergency where we see severe head trauma followed by intracranial bleed and seizures, and metabolic like hypoglycemia can cause seizures, hypocalcemia, hypomagnesemia, and hyponatremia, hypernatremia, and a few inborn errors of metabolism can present with seizures, and few toxins like lead and this INH and TCS can cause seizures. These are anoxic seizures because of breath holding spell, carbon monoxide poisoning, drowning, and cardiac arrest. Unprovoked seizure, there will be no identifiable cause for seizures. We'll call it as idiopathic seizures. So thank you all. This is the for nurses mainly our focus will be on actively seizing child presents to ER. We need to know how to stabilize the patient and to maintain the airway, breathing, circulation, and followed by initial administration of medication like IV lorazepam and or midazolam. Then based on doctor's advice, we need to go for second line antiepileptic, and we should give like infusion over 20 minutes. And we need to monitor the vitals of the actively seizing child, like to know the normal heart rate for the age, normal heart rate, respiratory rate, and saturation levels, and BP. If seizures persist, can cause hypertension, bradypnea, and may require intubation. We need to ready for intubation. So thank you. Thank you. You should know all this, whatever we discussed for ER management of seizure in actively seizing child. Okay, thank you.
So thank you so much for your insightful presentation. Now I would like to introduce Dr. Navita M. She successfully completed her fellowship in neonatology from Fernandez Hospitals. Her expertise is handling neonates with extremely low birth weight. Today, her presentation is on neonatal jaundice. Ma'am, over to you.
Back. So first we should know what is bilirubin metabolism. Basically, the unconjugated bilirubin in the blood, when it binds to albumin, it enters into the liver cell with the help of some proteins like liganin and other proteins. It is conjugated with glucuronic acid to become to conjugated bilirubin and enters into the biliary system. And from there, it enters into the gut. There, with the help of bacterial enzymes, it is converted 90% into urobilinogen and steatobilinogen and enters into the feces. But only the 10% enters back into the portal circulation, that is into the blood, and some part enters excreted through kidney. So, the part which enters into the blood, it is called as enterohepatic circulation. I am telling this because this is important to know what are the causes leading to the jaundice. So what is physiological jaundice? Physiological jaundice is a normal jaundice, usually appears after 24 hours. And the maximum intensity is on day 4 to day 5 in the term babies, on 7th day is in preterm. So usually the bilirubin levels does not exceed more than 15 milligrams per deciliter. And it is not detectable after 14 days and usually disappears without any treatment. But keep in mind that every baby should be watched for worsening of the jaundice. So usually the causes of the normal jaundice are because of increased bilirubin load. That is due to more red cell volume in the babies and also increased destruction occurring. And it can also be because decreased uptake from the plasma and defective conjugation and decreased excretion and more of enterohepatic circulation, as I explained before. So now pathological jaundice is a jaundice which occurs within 24 hours of life in the baby. And the bilirubin usually rises fast. It will be more than 5 milligrams per day. And jaundice usually persists for more than 14 days. And if you notice, the stool color will be clay or white in color and the urine will be high colored. It will stay in the cloths deep yellow. And usually the direct fraction in that will be more. It will be usually more than 2 milligrams per deciliter. So the causes here are, some may be similar to physiological, but it is occurring in excessive amount. Like excessive red cell hemolysis occurs because of enzyme deficiencies or some other reasons, and because of defective conjugation occurring in the liver, and other causes like metabolic problems, endocrine problems, more increased enterohepatic circulation, and the substance is not there in the body to bind to the bilirubin, and other miscellaneous causes. So from this, we can just remember more common, like physiological causes are more common, and the blood group incompatibility, ABO incompatibility and RH incompatibility are more common reasons. Other reason is enzyme deficiency, G6PD enzyme deficiency. And sometimes any bruising occurring, more bruising occurring on the body, and any bleeding occurring in the skull bone, intrauterine and postnatal infections, breast milk jaundice, congenital hypothyroidism, and prematurity. These are the most common reasons among them. So how to approach to a jaundice baby? So first of all, when we see the jaundice baby, every nurse should know what is the gestation age of the baby and what is the age of the baby and what is the birth weight. And they should be able to assess the clinical condition if the baby is the baby well or very sick. So whether the jaundice is physiological or pathological. And also look for any connective signs present in a deeply jaundiced baby. That is, there will be decreased in activity, poor feeding will be there, and they may have abnormal posturing and sometimes seizures. So this is there is one clinical assessment on jaundice, like it is called as Kramer score. Based on area of the body involved, the bilirubin levels can be assessed. The face part has some value, the upper trunk, lower trunk, and thighs has some. So just to know a clinical assessment, Kramer scoring may help you. Other way to investigate to know the jaundice level is transcutaneous bilirubinometer. Through the skin, we can detect the bilirubin levels. It is ideally done in more than 35 weeks of gestation age babies, but unreliable after starting of phototherapy. This is a baby and the measuring of jaundice done through Billy chip. So the laboratory test available to detect neonatal jaundice in the babies are, first of all, to know how much is the bilirubin. In that total bilirubin, direct and indirect bilirubin, what is the blood group and blood group of the baby, and RH of the mother and the baby. What is the hematocrit, retic count, and peripheral smear. Sepsis screen if the baby is really sick, and if the baby is having the pathological jaundice, extra tests like liver function test, thyroid function test should be done. Other tests include enzyme deficiency like G6PD deficiency, and also sometimes red cell enzyme assays should be done. And if any intrauterine infections are suspected, torch titers should be checked. And sometimes radiological investigations like liver scanning needs to be done. So what is the treatment part? Treat the underlying cause, and our goal should be the reduction of bilirubin levels. It can be through phototherapy or exchange transfusion, and sometimes drugs, which are used very rarely. And our goal should be prevention of hyperbilirubinemia by giving early feeding and giving adequate feeds and maintaining adequate hydration in the baby. So there are some guidelines for use of phototherapy and exchange transfusion in the babies. Nice guidelines on neonatal jaundice recommend some treatment thresholds that are specific as per gestation age. Each gestation has one specific chart. It is from 23 weeks to 38 and more weeks of gestation. Usually after 38 weeks, it is taken as 38 weeks of gestation age. And other guidelines are AAP recommendations. They are our specific nomograms like measles chart and Botany chart. Measles is used for less than 35 weeks of gestation, Botany for more than 35 weeks of gestation. So the types of phototherapy lights we use are compact fluorescent lamps, CFL lights, and other is high intensity light emitting diodes, LED lights, and others are fiber optic units. Exposing the baby to sunlight does not help in treatment, and it is associated with risk of sunburns. Here is the baby receiving intensive phototherapy with triple unit lights. These are CFLs with fiber optic blanket. And here, if you notice, the eye shield is there, and the genitals also needs to be covered. Here we could not see clearly. The technique of phototherapy. Before giving phototherapy, the proper hand washing and placing the baby naked under the warmer or incubator. Fix the eye shields properly, cover the genitals, keep the baby at least 30 to 45 centimeters from the lights. And if you're placing the lights closer to the baby, please monitor temperature regularly and start phototherapy. During phototherapy, frequent feeding should be done every third hour. Turn the baby after each feed. Temperature recording should be done regularly, and also weight recording daily. Monitor urine output, monitor bilirubin levels, minimum after at least 12 to 24 hours after giving phototherapy. Stop phototherapy when the bilirubin levels fall to the safe levels. So during what are the common side effects of phototherapy are? There is increased insensible water loss can happen, which can lead to dehydration, and there is increased frequency of stools. Skin rash can occur, and sometimes hyperthermia. Dangerous things are retinal damage and testicular damage. To prevent this, every nurse should monitor during giving phototherapy to the baby. What are the indications for exchange transfusion? This is one of the treatment modality after giving phototherapy to treat jaundice. Usually it is done when the phototherapy fails to prevent rising bilirubin levels, and most commonly done in the hemolytic disease of newborn, like in ABO incompatibility or RH incompatibility. and the baby is having severe sepsis. All these are the indications of exchange transfusion. So what is the equipment? You should keep it ready in your unit for the exchange transfusion. Radiant former and respiratory and cardiac support equipment should be ready. Suction equipment should be ready. Multi-channel monitor during exchange transfusion. Umbilical catheterization set and others should be ready. The blood given to the baby should be leukodepleted, irradiated, and compatible blood products should be used. Exchange transfusion done through umbilical vein catheterization. It is done under strict aseptic precautions by push and pull method. Baby receiving exchange transfusion. So what are the complications related to exchange transfusion? Like hypothermia can occur, cardiac arrhythmias may lead to cardiac arrest sometimes. Electrolyte imbalances are common complications, hypoglycemia, hyperglycemia, coagulopathies and infections. So this complication should be monitored and regular blood tests are done during the procedure and after the procedure. So one more important topic is conjugated hyperbilirubinemia. It is like a pathological jaundice. In this, usually the direct fraction is more than 20% of the total bilirubin. And also you can suspect clinically when you see the child is passing and when the baby is passing white or clay-colored urine, clay-colored stool, sorry, and the urine is very high colored, then we have to suspect conjugated hyperbilirubinemia, and it is a medical emergency and should be treated, should be investigated and treated as soon as possible. So what can be the causes of conjugated hyperbilirubinemia? It is idiopathic neonatal hepatitis, intrauterine infections, sometimes severe sepsis in the baby, sometimes congenital causes like enzyme deficiencies, alpha-1 antitrypsin deficiencies, surgical causes like biliary atresia, choledochal cyst, cystic fibrosis, metabolic causes, galactosemia, thyrosinemias, most common hypothyroidism, and sometimes prolonged parenteral nutrition can also lead to conjugated hyperbilirubinemia. So how to approach to this? So most commonly we have to rule out an infection in the baby by sending routine bloods. In that urine culture is must, blood culture, and to rule out syphilis VDRL, metabolic screening if any congenital anomalies or suspected, and if the genetic suspicion is there, can investigate further with alpha-1 antitrypsin deficiency for cystic fibrosis. If intrauterine infections are suspected, torch profile need to be done, and other investigations as discussed, ultrasound abdomen and hepatobiliary scan and liver biopsy. So first of all, management is to treat the underlying cause. Like if any infection is suspected, treat with antibiotics or antiviral. Galactosemia is suspected. It is also most common reason in that galactose-free diet needs to be given. Other causes like fructosemias and special diets are available. They need to be, we should avoid fructose or sucrose diets in the baby. Other like liver causes may need liver transplantation or DVT, double volume exchange transfusion, sometimes immunoglobulins. And in hypothyroidism, thyroxine should be supplemented. Surgical causes, treat with surgery. The most important thing is in conjugated hyperbilirubinemia, most important part is giving adequate nutrition by giving high caloric diet, and protein should be restricted to 2 to 3 grams per kg per day, and fat soluble vitamins should be supplemented. The medications to increase the bile flow like udiliv and phenobarbital should be supplemented. Thank you. Hope by the end of this lesson, one can identify the neonatal jaundice and help the babies. Thank you. Stop.
Welcome back to the symposium. I take immense pleasure in introducing our senior most neonatologist, Dr. Ravindra Reddy Parigi. He is heading the Department of Neonatology and Pediatrics in Women and Child Unit, Madhapur. He has over 19 years of experience, which includes 13 years of experience in United Kingdom. He successfully completed his MRC PCH, FRC PCH, and training from United Kingdom. He is expertised in management of extreme preterm babies, extreme sick term babies, persistent pulmonary hypertension in newborns, and therapeutic hypothermia. He has 4 international publications to his credit. I would like to welcome Dr. Ravindra Reddy to proceed with his presentation. Over to you, sir.
Thank you.
Hi, good morning, everyone. Thank you, Sangeeta, for the nice introduction. I welcome you all for this session. I hope you're all fully awake now after the coffee and tea break. I thank you, the nursing team and admin team, for taking this initiative and to conduct this event. I congratulate them, and I wish we continue to do these modules at regular intervals. Coming on to my topic today, I'm going to talk about care of neonates with COVID-19. This is, as we all know, it's a burning topic, burning problem across the globe. What is coronavirus? We all know it's a new strain of coronavirus. Coronavirus disease 2019, CO stands for corona, I stands for virus, and D for disease. It is a new strain first identified in Wuhan, that is in China. The virus is transmitted to direct contact with respiratory droplets of an infected person, generated through coughing and sneezing. If you look at the numbers overall, these are the numbers from yesterday. Worldwide, there are more than 20 crores coronavirus patients or coronavirus cases. In India, if you look at it, it is more than 3 crores. Deaths overall 43 lakhs plus. In India, 4 lakhs plus until yesterday. If we look at the COVID-19 in newborns, where are we and what should we be doing and where we should concentrate? Before going into newborns, first I thought we'll discuss about COVID in pregnancy. I'm not going in detail about COVID in pregnancy, just a brief discussion on COVID in pregnancy, then I'll move on to COVID in newborns. Recent studies report that pregnant women with COVID-19 are at increased risk of getting severe infection, COVID infection, and also there is a risk of various pregnancy-related complications like preeclampsia, eclampsia, diabetes, and thrombosis. Though the incidence of COVID-19 in pregnancy is similar to general population, but the manifestations or the clinical features are more severe in pregnant women. If you look at the percentage, 74 to 86% who tested positive for COVID were asymptomatic. This is, if you take 100 pregnant women who were positive with COVID, 74 to 86% were asymptomatic. 10 to 13% of symptomatic women had severe disease requiring ICU admission. This is a significant number. 10 to 13% of symptomatic women had severe disease requiring ICU admissions. Quoting this, we recently had 2 preterm babies in our hospital who were born preterm, whose mothers were diagnosed to have COVID, who were in ICU on the ventilator. Successfully, both mothers recovered, had preterm deliveries, and both babies went home, and both that families are happy now. And there was another incident, unfortunately, we lost the mother. We needed to do the section in the ICU, in the medical ICU itself, because mother was so extremely unwell. That was again preterm delivery. Baby managed to survive. Baby proved to be strong, but unfortunately, we lost the mother maybe 1.5 days later after the section. Effects on fetus, COVID-19 in pregnancy. What are the effects on fetus? It is associated with increased risk for stillbirth, IUGRs, and preterm births. These adverse effects are more pronounced in the ladies who are symptomatic. Just a quote on preterm birth. Day before yesterday, there was an article. It was a study, largest study in US. They have studied around 240,000 pregnant women who were positive for COVID over the past 6 months. Out of 240,000, there were 9,000 births who were less than 32 weeks of gestation. So it's a quite significant number. Among the neonates, so now we look into COVID in newborns. Among the neonates born to COVID positive mothers, the incidence of positive test in newborns ranges from 0.5 to 13%. In India, there was a multi-centric study recently that was under NNF COVID-19 registry. There were 1711 neonates reported a 10% positive rate. Mode of transmission, how neonates get COVID infection. There are 3 possible ways. One is transplacental passage from mother to fetus. That is while the baby is inside the womb. This mode of transmission is relatively rare. And the number 2, direct exposure to maternal blood or secretions during delivery. Number 3, third mode of transmission is through aerosol or direct contact from infected mothers or caregivers, including the healthcare workers. How do we classify neonatal COVID-19? There are we can classify in 2 forms, early onset and late onset. Early onset is likely to have been acquired during delivery or in the immediate postpartum period. The onset of illness is within the first week of life. Generally, it is between 2 to 7 days. Early onset COVID is relatively less common. Most of the babies remain asymptomatic or mildly symptomatic. If you look at late onset illness is beyond the 5 to 7 days of life. Most neonates become symptomatic at home after discharge. Postnatal transmission from mother or immediate caregivers plays a significant role in late onset neonatal COVID-19 infection. As the infection is usually diagnosed when the neonate becomes symptomatic, the clinical features are relatively more severe. What are the clinical features? Mild symptoms like cough, cold, low-grade fever, and 10 to 15% of the neonates may develop moderate to severe symptoms like respiratory distress, lethargy, feeding issues, vomiting, diarrhea, and hemodynamic instability, that is abnormalities in the blood pressure or tachycardia. I thought of mentioning this important entity we are seeing in children. So it is also happening in neonates, that is called multisystem inflammatory syndrome in neonates. What it is multi-system. It's just, the name itself tells us it involves many systems. It can involve, sorry, this condition may present during the COVID illness or 2 to 6 weeks after the COVID illness. It involves the multi-systems like breathing, that is lungs, heart, GIT, CNS, kidneys, liver, sometimes skin, eyes, etc. So it involves multi-system, and it's significantly a serious disease, but if you diagnose early and treat promptly, outcome is very good. So it is called multi-system inflammatory syndrome in children. If it happens in children, in neonates, it is called MIS-N if it happens in neonates. It's rare, but we should know about this condition. The exact reason of this condition is not known. It is thought to result from neonatal hyperimmune response to maternal antibodies transferred across the placenta. Neonates with MIS can become critically ill with severe multi-organ dysfunction. If it involves lungs, they can have respiratory distress. If it involves heart, then abnormalities in the blood pressure, heart rate, sometimes involvement of coronary arteries. If it involves CNS, then fits, skin rash, eyes, red eyes, kidneys, they can have issues with renal output, so on. The timing of presentation of MIS depends upon the timing of maternal infection with COVID. Therefore, it may present in utero. MIS can present in utero or immediately after birth if the mother was infected early in the pregnancy, or it may present 2 to 3 weeks after birth if the mother was infected later part of the pregnancy with COVID. This is very important, rooming in of neonates. So where are we going to keep these neonates? Healthy neonates should be roomed in with their mothers. When roomed in, exclusive breastfeeding must be prompted. COVID-19 virus, there is no evidence that COVID-19 virus is excreted in the breast milk and it is not harmful. Hence, we should promote breastfeeding. Obviously, mother should wash hands before, frequently, including before and after breastfeeding. Mother should wear an appropriate mask if direct breastfeeding is not feasible due to neonatal or maternal condition. Encourage express breast milk. KMC, that is kangaroo mother care. We all, especially the nurses who work in NICU or nurseries, are aware about KMC. That is kangaroo mother care. It should be provided to all stable low birth weight neonates irrespective of mother's COVID status. It can be initiated as early as mother's medical condition allows. If the mother is not able to provide KMC due to her medical condition, the father of the neonate or another healthy family member who is not symptomatic and is tested to be COVID negative can provide skin-to-skin contact. Frequent change of such persons providing KMC should be avoided. We should restrict on to one person, either father or mother or extended family member, just only one person. Persons who provide KMC should follow all COVID precautions. Care area for neonates, like where are we going to keep these babies? Symptomatic neonates with suspected infection should be isolated from other healthy mothers and neonates. Obviously, symptomatic neonates should, with suspected COVID infection who test negative, should undergo repeat testing after 24 to 48 hours, but they should be isolated from healthy mothers and the neonates too. So we should keep these suspect neonates or symptomatic neonates from separate from other healthy mothers and neonates. When do we test neonates? Between 24 to 48 hours of age after birth. Rooming in should not be postponed if testing is delayed. In case of early discharge, we should take a pre-discharge sample. Say, for example, if baby is well, if the parents or relatives want to take the baby home, Yes, we are allowed to send the baby home, but please take the sample before discharge. A repeat test is desirable at 5 to 7 days of life. That is ideally it's useful if you repeat the sample or swab test at 5 to 7 days of age. Say, for example, asymptomatic high-risk contacts to be tested once between 5 to 10 days of coming in contact. Symptomatic neonates, irrespective of the history of exposure, we should test at the onset of illness or at the time of first evaluation by a healthcare professional. These two are important. One, we are talking about asymptomatic high-risk contacts who have come in contact should be tested between 5 to 10 days of coming in contact. And this clear difference, symptomatic neonates, we should test at the onset of illness or at the time of first evaluation. If the index of suspicion is high and the initial test is negative, it's always good to repeat swab test in 24 to 48 hours of life. Sorry, 28 to 48 hours after the initial test. What are the investigations for COVID-19? What are the investigations we do? In neonates with suspected or confirmed but asymptomatic or mild COVID-19 infection, generally we don't do any laboratory tests apart from RT-PCR or CBNAT. In neonates with symptomatic, moderate or severe COVID-19 illness, we do relevant blood tests like CBP, CRP, etc. Just to obtain the information about severity, progression, and complications, or to rule out other coexisting illnesses. How do we treat? Specific anti-COVID-19 treatment is not recommended in symptomatic neonates with confirmed or suspected COVID-19. Use of intravenous gamma globulin is not recommended in symptomatic neonates with confirmed or suspected, other than in scenario of suspected multisystem inflammatory syndrome. So this is very important. We should yes help these babies, but by giving supportive treatment. But there is no specific COVID treatment. Use of steroids, is it beneficial? Yes, in some neonates with severe or critical COVID-19 requiring ventilation. When do we discharge these babies? Stable neonates exposed to COVID infection and roomed in with their mothers may be discharged along with their mothers or sooner if the relatives are okay. Stable neonates in whom rooming in is not possible because of the sickness of the mother, as I said, may be discharged if the relatives are okay to look after this baby. Follow-up. How do we follow these babies? All neonates born to mothers with COVID-19, regardless of neonate's COVID status, should be followed up at least for 14 days and preferably 28 days of life. Wherever the physical visit is not possible, we also encourage telephonic follow-up, or they should contact the nearest pediatrician. Immunization policy for neonates. So follow routine immunization policy in healthy neonates born to mothers with COVID suspected or confirmed COVID-19 infection. In neonates with suspected or confirmed infection, vaccination should be completed before discharge. Except in special situations, say for example, if the baby has had steroids or immunoglobulins, then we should discuss about the vaccinations. But in all other babies, we should give vaccinations before discharge. Thank you all for listening. I hope you carry on a few points from this session into your clinical practice. And I hope to see you all in the near future at regular intervals. And I wish you all the best. Thank you.
So thank you so much for your time and enlightening presentation. There are many assumptions going around the third wave and how it is going to affect the children. Even though there is no strong evidence about it, media has already covered a very broad coverage. We have received many calls from apprehensive patients. To clear the clouds of apprehension, we recently launched a booklet of third wave, myths and facts. How can we protect children from the third wave? I'll post the link in the chat box. It will be a kind of helpful for the nursing staff as well as the other supportive staff. Thank you so much. Session is open for question and answers forum. If anybody has any questions, they can ask here or they can write in the chat box. Thank you. Now, I would like to introduce our next speaker, Dr. Himabindu M. She's a consultant pediatrician from Karnool. She's expertised in handling birth defects, neonatal ventilation, central line care for neonates. Ma'am, over to you, ma'am.
Hi, good Hi, good morning, everyone. Today, my topic of discussion is neonatal hypoglycemia. So, most of the metabolic problem what we encounter in the neonates, actually neonate means baby like less than 1 month age. And so I'll be discussing like definition, what are the signs and symptoms of hypoglycemia, and what are the investigations, treatment and prevention, what and all to be done. So since this is the most common problem which we encounter in the NICU, usually the sisters who are posted in the NICU should be like sensitized to identify the signs and symptoms and when to intervene.
Ma'am, your voice is little slow, ma'am. Can you louder?
Yeah. So sisters should be sensitized regarding when to intervene, like when to check the GRBS and in which babies the GRBS has to be monitored, and like what intervention has to be done, like if the GRBS is low. And this is the most preventable cause. Usually if the baby is having a hypoglycemic episodes, the chances of having neurological damage will be more in these children. So this is a preventable cause if you do a screening of GRBS in these babies. And we should know why these neonates are more prone for hypoglycemia. Usually when the baby is in the in utero, like inside the mother's uterus and all, there will be supply of glucose for the babies from mother to baby through the umbilical cord. Once the baby delivers, then there won't be any loss of, there will be loss of supply of glucose from the mother to the baby. And these babies also will be having, usually if you are in if you are not taking anything orally, usually everyone will have this glycogen stores. But neonates, they'll have this inadequate glycogen stores. And these adaptive mechanisms also will be like immature in the neonates. And there is one terminology called transitional hypoglycemia. Usually what happens is when the baby delivers, initially the first 1 to 2 hours, sugars levels will be like the GRBS will be low, like 25 to 40 it might be ranging. But usually by 3rd to 4th hour, this GRBS levels will be normal. So you should know like when if you think like 25 to 40 is very low and the baby is very well baby and all, no need of intervening at that moment. You can ask the mother to feed the baby, and then you can recheck the GRBS again at 3rd hour of life or the 4th hour of life. And there are regarding this neonatal hypoglycemia, there are multiple definitions, but there is a recent guidelines advise us blood glucose levels should be less than 40. Here I have added a terminology called plasma glucose levels. Usually what we do for checking the GRBS is we'll do a heel prick, that is a blood glucose level. And what we do in the lab, sometimes we'll send the RBS sample, that is a plasma glucose. So two are different terminologies. Usually most of the time plasma glucose will be like 10 to 15 milligram per deciliter more than the blood glucose levels. So only I have to add these two terminologies here, blood glucose levels and plasma glucose levels. So if the baby is having blood glucose levels, like what GRBS testing which you are doing, if it is less than 40, you have to intervene. And the intervention, again, you have to divide the baby, whether the baby is having any symptoms or not. And usually this incidence of hypoglycemia is more in this high-risk neonates. Like I'll tell you which are the high-risk neonates, like which babies needs more screening for neonatal hypoglycemia. So usually what and all you have to watch, like what signs and symptoms is, what happens is sometimes the mother will bring the baby, like for suppose the baby is delivered and at 4th hour of life, they'll usually complain like a baby is not taking feeds well, or a baby is not sucking, or baby is like dull activity, even to the painful stimuli, baby is not responding. So usually most of the time from the general wards, general wards means the baby is next to the mother, like normal babies will have these symptoms. So everyone in the wards and the NICU, they should be sensitized regarding when to check the GRBS, because if we intervene early, the chances of baby having a neurological problem in the later on life will be less. So what and all signs and symptoms is irritability, if the baby is having any tremors, jitteriness means like shaking little, and tachypnea. Sometimes baby will not be having any lung issue. Because of this only hypoglycemia, they will be having hurried respiration and sweating. And if the baby is paler means like a pale color, the baby will become a pale color, even though baby will be having enough hemoglobin and all. And one of the most common cause of this hypoglycemia is hypothermia. What these people do is most of the time they won't adequately keep the baby warm. If the baby is hypothermic means if you are maintaining temperature of 36.5, the baby is having very low temperature, then they have to utilize more glucose to maintain the temperature. So then they'll go for a hypoglycemic episodes. So we have to counsel the this primary mothers how to take care of the baby. And sometimes only manifestation, if the baby is in the NICU, sometimes only manifestation of hypoglycemia will be the increased heart rate. Means the baby will not, usually tachycardia will get in in a pediatric or adult cases when the baby is in the shock, or if the baby is having any fever, or if the baby is excessively crying, only will be having this increased heart rate. But in hypoglycemic episodes, sometimes the only manifestation will be only the increase in heart rate. So if the baby is not having the other shock features or fever and all, this hypoglycemia should be kept in mind. Previously I have told you like baby will be having poor suck, refusal to feed, hypotonia. Sometimes when you see in the emergency room, most of the time we'll have these issues. In the emergency room, sometimes they'll bring a 3-day-old baby or a 4-day-old baby only with a history of seizures. Seizures means fits. So in the emergency room, initially you have to check the GRBS, because one of the cause for this metabolic cause for seizures is hypoglycemia. So instead of loading anti-epileptics and all, first you have to check the GRBS. Once you correct the hypoglycemic episodes, most of the time the seizures will subside off. And sometimes baby will come in the comatose, means even not responding to the painful stimuli. They'll give a history of since 1 day or 2 days baby is not taking any feeds well. So this is also a correctable cause. And if you see NIC babies, they'll be having this apnea, means they'll stop breathing for some time. We'll call like cessation of breathing, and they'll have irregular breathing patterns. And some babies, there'll be only cyanosis. Cyanosis means this bluish discoloration of the lips, hands, and the soles. And some babies will be having a high-pitched cry. And usually there'll be a signs of hunger. Usually the baby is hungry. Sometimes they will turn the head to one side, and sometimes they'll keep their hand in the mouth, and sometimes they'll do excessive crying. These are excessive hunger signs. And sometimes in the vomitings, if the child is having any vomitings, also you have to check the GRBS. So the next question comes, for which and all babies you have to check the GRBS routine. Do we check for the all babies or some particular high risk babies? Usually if the baby is healthy and above 2.5 kg and a term baby, usually term, preterm, there will be two terminologies. Term baby means if the mother has completed more than 37 completed weeks of gestation. If the baby is healthy, more than 2.5 kgs, and if the baby is feeding well, no need of doing any routine GRBS screening for these babies. Only for the babies which are like less weight, like less than 2.5 kgs, and the preterm babies which are less than 35 weeks. Here I have mentioned SGA, it is a small for gestational age. Usually what we do is, if the baby is born, we have to check the weight, and according to the gestational age, there will be a growth chart. We have to plot on the chart where the baby comes, like there will be centiles charts. So if it is less than 10th centile, then we'll call the baby as a small for gestational age baby. And if the baby is more than 90th centile, then we'll call them as large for gestational age. Here I have mentioned as LGA and SGA. And IDM, infant of diabetic mothers. And if the child is having any hemolytic, the mother is O negative, A negative, and baby is O positive or A positive, they'll RH hemolytic disease. Some babies will get admitted only for a jaundice and anemia. And IUGR babies, and if you are doing any exchange transfusion for that babies also, in the first immediately after the exchange transfusion, again after 1 hour you have to check the GRBS. And if the child is on any IV fluids and total parenteral nutrition, and if the baby is a very sick baby, like most of the babies in the NICU, they get admitted for sepsis, like perinatal asphyxia. Perinatal asphyxia means if the baby doesn't cry immediately after birth, requiring any resuscitation. And if the mother is on any, usually in the case sheet will mention if the mother is on any drugs, like if the mother is diabetic or mother is on any Lebitlol tablets or injections. And during the delivery, before the delivery, if the mother is on any IV fluids, dextrose containing IV fluids. These are the indications to check the routine GRBS monitoring for these babies. And this is the screening schedules. Usually in the every NICU, they can paste this like what do you say, poster type, so that everyone, sisters will be sensitized regarding this. Previously I have mentioned all the neonates, they are called at-risk neonates. For them, usually 2 hours, 6 hours, 12 hours and 24 hours. Usually these 2, 6, 12 and all are calculated based on that hours of life. So here, if it is 2 hours, means at the 2 hours of life. So based on this screening schedule, you have to check GRBS for these babies. And if it is a sick neonate, every 6th hourly or the 8th hourly, you have to check GRBS. And this low birth, very low birth weight babies, and on who are on total parenteral nutrition, initial first 3 days you have to check 6th to 8th hourly, and after 3 days once daily is fine. And usually this infant of diabetic mothers, most of them they'll be in the ward side only if the baby is stable, not having any hemodynamical instabilities. So for them in the ward side, you have to check first hour, second hour, third hour, 6th hour, and 12, 24, 26, and 48 hours of life. And this exchange transfusion babies, immediately after the exchange, usually during the exchange transfusion also, in between we'll be checking the GRBS. And after 1 hour after the exchange transfusion also, you have to check the GRBS. This I'll be discussing later, this line. Then question comes, how we are going to estimate the random blood sugar in these patients. Usually point of care of testing, POC will tell. Usually what we do in the NICU or the ward side is, you will check it with a reagent strip or the glucometer. So usually this is the widely used method, but what we are checking is the whole blood glucose, so which we are doing a heel prick. So it will be usually 15% lower than the plasma volume. Why it is important is, if the baby is getting repeatedly low values of GRBS, usually you have to confirm it by the laboratory method. Laboratory method means again you have to take a sample for a random blood sugar. So if before giving the correction, if it is also low, then baby is having truly hypoglycemic episodes. So only they have mentioned like it is usually unreliable at a lower values. And the next method, lab method, what we are doing is glucose oxidation method, oxidase method. Usually it is a reliable method and accurate method. And sometimes we this is little expensive, glucose electrolyte method. But advantage of this method is minimum volume of blood is required, and at the same time we can estimate the lactate levels also using this glucose electrode method. But routinely in our hospital we are doing only GRBS, means a reagent strip method, and glucose oxidase method. So next question comes, if you see a NIC baby, most of the time there will be multiple pricks everywhere on the foot of the baby. So this is the important chart, and this chart also has to be like a poster type in the NICU, so that if the sisters are newly trained and all, it will be helpful from them to check where to check for the puncture sites. Usually it will be the medial sites or the lateral side. Here I have mentioned points like puncture sites and all. Only in that areas you have to check the GRBS, and it should be a lancet type needle, and the insertion depth is 0.8 mm to 1.5 mm. Sometimes what most of the time, like if it is a not trained sister, what they do is they'll take some 10 cc syringe or a 5 cc syringe needle and they'll puncture, because they're going to what do you say? There will be chances of more bleeding if you use a wild boar needle, and you are giving more trauma. And sometimes what happens is in the posterior aspect, if you go little posterior in the heel side, there will be chances of damaging the calcaneal bone. So if you go, if you give a deeper prick, there will be chances of osteomyelitis for these babies. So only you have to, this whatever have this orange zone, whatever mentioned is the puncture site, you have to maximum try to puncture the baby, like check GRBS in this site, and the insertion length, depth of insertion should be 0.8 mm to 1.5 mm. And this is the method of between the thumb and the index finger, you have to hold the heel of the baby. And best way is you have to try and feed the baby so that baby will be little comfortable. Usually they'll tell because of the glucose, it acts as also a painkiller type. So if the baby is taking like adequate feeds and all, so they will be sleeping, so there will be less pain to the baby. So most of the time, like if you don't use this adequate method, like holding the baby, if you are giving a prick, most of the time there won't be any blood. So again, we'll squeeze the sample. So there will be chances of false, false values will be there. And you have to know when to treat the baby, like whether we should give an IV fluids or we have to just feed the baby. Usually there is again two terminologies like asymptomatic, symptomatic. So once you see the baby, if the baby is absolutely fine, like baby is active and no other signs like no tachycardia, no irritability, and baby is like maintaining saturations, no other issue, and still blood glucose is less than 45 milligrams per deciliter. And it has to be confirmed by the laboratory estimation also, if the baby is stable. Then it is called asymptomatic hypoglycemia. Then what you have to do is, you can ask them to feed the baby. If the baby is asymptomatic, you can ask them to feed the baby, and after 1 hour, you have to recheck the GRBS again. If the repeat GRBS is again more than 45, then you can ask them to second hourly feed the baby and again recheck GRBS every 6th hourly for the next 2 days. If the repeat GRBS, I told you like first initially you have to feed the baby and again after 1 hour. If the 1 hour GRBS is less than 45, you have to confirm it by the lab report. But this time you have to treat it as a symptomatic hypoglycemia. The next terminology is symptomatic hypoglycemia. Usually symptomatic means previously I have told you like signs and symptoms what we get in hypoglycemia like irritability, cyanosis, tachycardia and all. Sometimes seizures. So their GRBS will be like less than 45 milligrams per deciliter and they'll be having coexisting any clinical symptoms. So here you have to treat like if it is a symptomatic hypoglycemia, we have to go for IV fluids only. And here I have forgot to mention, if the baby is asymptomatic, but GRBS is less than 20 milligram per deciliter, you have to go by IV dextrose only. And in the first 1 day, like 24 hours, you have to maintain GRBS more than 45. And later on, the next after 24 hours, it should be more than 50 milligram per deciliter. And symptomatic hypoglycemia, you have to give 2 ml per kg of 10% dextrose over 1 minute. Here the question comes like when to check. Again, after 15 to 30 minutes, you have to check GRBS and you have to check whether it is maintaining more than 50 or not. If it is still less than 50, again 2 ml per kg bolus can be given. So once you know it is a symptomatic hypoglycemia, immediately after giving the bolus, you have to start the child on a GAR. GAR means glucose infusion rate, like 6 to 8 mg per kg per minute. If the blood glucose levels are stable and if the baby is stable, better to start feeding as early as possible so that you can taper the GRBS. You can taper the GIR. This is the AIMS protocol 2014. They have clearly given when to intervene, when to not intervene, and what are the types, like whether it is symptomatic or asymptomatic. Previously, I have told you asymptomatic, if it is less than 20, you have to treat it as symptomatic only. Symptomatic means you have to consider the baby as a sick baby, then you have to give 2 ml per kg of bolus. If it is asymptomatic baby with 20 to 45 trial of oral feeds, again after 1 hour you have to check the GRBS. Main issue comes in the symptomatic babies. Here immediately 2 ml per kg bolus has to be given and you have to give a glucose infusion rate of 6 mg per kg per minute. Then you should know what is the normal value after 1 hour. Initially we were discussing 40 or 45 is hypoglycemic episodes. After 15 to 20 minutes, then GRBS levels should be more than 50. If it is more than 50, then you will start IV fluids and you have to check for GRBS, like a minimum 2 values should be more than 50. Then next is if the blood glucose level is less than 50, still even after starting a 6 to 8 mg of mg per kg per minute of JR, then again you have to increase the JR by 2 mg per kg per minute. Usually till more than 12 will go, like 12 mg per kg per minute to maintain the GRBS levels. Even if it is not responding with 12 mg per kg per minute, then we have to take a help of, we have to give hydrocortisone injection and all. And meantime, we have to send the critical lab samples. This is a little different entity. Till here, it's fine, like till 12 mg per kg per minute. Here, there is a need for a exact in the timings. You have to maintain the chart, like at what times you want to check the GRBS. Because here, if the GRBS is more than 50, I have informed, I have told here, if the values is more than 2 values or more than 50, then you can start the weaning and you can increase the oral feeds also. So this by time to time screening of GRBS is important because we'll know when to decrease fluids or increase the fluids. Next, this is a formula how to calculate the JR. Usually, here F means IV fluids, like how much ml per kg per day, into the what is the dextrose, like how much percentage of dextrose. Usually in the peripheral line, we'll go ahead with only like maximum I can give is 12.5% dextrose. If it is above 12.5% dextrose, you can't give it in the peripheral line. Again, you have to go for the umbilical line. And this is a practical prompts, like if it is still more than 45, like less than 45, every time you have to increase 2 mg per kg per minute. And if it is more than 45 blood glucose levels for 24 hours, then you can start tapering the GRBS levels, and this timing of screening also will decrease. Here you can check the GRBS every 6th hourly. And once if it is 4 mg per kg per minute, usually 4 mg per kg per minute means what this maintenance fluids which we are giving to the baby, it routinely comes to 4 mg per kg per minute. Then if the baby is euglycemic, means if the baby is maintaining glucose levels adequately, then you can stop the IV fluids. In the peripheral line, you can't give more than 12.5% dextrose. And most of the time in the NICU, what happens is if the baby is having persistent hypoglycemic episodes, you have to check the IV line once. Even if you are giving the treatment, still baby is not responding. Even like we have to check whether there is a continuous infusion of this glucose fluids or not. And you should not stop the infusions abruptly. And oral feeding, like breast milk should be started as soon as possible if it is not contraindicated, unless until. And next is how to prevent. Usually what happens is when the baby delivers, we have to immediately start breastfeeding the baby. Like we have to encourage the mother. Like initially it was like for normal delivery within 30 minutes. Like in the LACS it is 1 hour. But now recent guideline says that as soon as possible. So what happens is usually in the first day of the life, even if the mother is not getting any milk, even that colostrum is enough for the baby to maintain blood glucose levels. So we have to encourage early exclusively breastfeeding. And one other cause of this hypoglycemia is what the patient attendants do is they'll take the baby for bathing and all, immediately the baby is born. So we have to encourage delayed first bath. So you have to tell the patient attendants like you have to keep the baby warm, and they should make they have to maintain the temperature, and the baby most of the times it will be like with the patient attendants, then with the mother. So you have to encourage the mother to keep the baby like skin to skin contact with the mother, and it should be like next to the mother. And sometimes what patient attendants do is they'll get some glucose or some honey from the outside, and they'll use it as a substitute for the breast milk. This will cause more infections to the baby. So you have to like counsel the attendants repeatedly. like not to give outside feeds or this dextrose containing solutions. And other issue I told you, like most of the time IV can swelling or to keep the antibiotics, sometimes you will stop the IV glucose infusion rates and all. So if the baby is hypoglycemic, there should not be any interruption in the IV glucose infusion rates. This is like what we think is like if the baby is not having any symptoms, doesn't mean that baby does not had any CNS injury. So only even if the baby is asymptomatic, we have to screen the baby like 6th hourly or 8th hourly depending on the baby's condition. And if the baby, like our goal should be in the first day of life, it should be GRBS should be more than 45, and later on after the 24 hours, it should be more than 50. This has to be kept in mind. Thank you. Hello. Thank you.
Ma'am, thank you so much for being a part of the symposium. Indeed, it is an insightful and outstanding presentation, and we are looking forward for the same kind of support for our future symposiums and workshops. Thank you once again. Now, I would like to introduce our next speaker.
Ma'am,
Any questions from audience? Ma'am, there is a question, madam, how we know newborn baby is affected with diabetes? Someone has posted in the chat box.
Yeah, usually most of the time it's unlikely like baby will be affected with diabetes. Usually if the mother is diabetic, then mother will be having this high glucose levels. So there in utero, like through umbilical cord, there will be more transfer of like high GRBS levels from mother to baby. So usually we have to screen the baby for hypoglycemic episodes. So if the mother is diabetic, doesn't mean that baby will be also affected with diabetic initially in the newborn period. So later on in the adolescent age, like not adolescent, when the baby is an adult, in the adult age and all, then if they are having any symptoms of diabetes, then you have to check. Usually it is unlikely like baby getting affected with diabetes. It's a very rare condition. Only with the diabetic mothers we screen the babies. It doesn't mean that we are not checking for a diabetes in the baby. We are checking only for hypoglycemias for the baby. Usually these children, these babies will be these babies are more prone for hypoglycemic episodes. That we screen these babies only for the 48 hours. After 48 hours, we are not going to screen these babies if they're not having any hypoglycemic episodes. Thank you.
Thank you, ma'am. Any more questions from audience? Thank you. Ma'am, can you please stop sharing your screen? Yeah, thank you so much, ma'am. Now, I would like to introduce our next speaker, Dr. Akshay Kumar. He's a consultant neonatologist from Karimnagar. He has successfully completed his fellowship in neonatology. He has over 5 years of experience. Now he's presenting on Kangaroo Mother Care. Over to you, sir.
Thank you. Good morning, everybody. Myself, Dr. Akshay Kumar. I am a consultant pediatrician and neonatologist at Medicover Hospitals, Karimnagar. Today, I am going to discuss about kangaroo mother care. So, what is this? What is kangaroo mother care? So, kangaroo mother care is nothing but a method for care for the preterm and low birth weight babies. So, it is by giving skin to skin contact with mother or other caregiver as father or grandfather. Anybody can give this kangaroo mother care. This is for optimum growth and development of the baby. So there are two components in kangaroo mother care. One is skin to skin contact and other one is exclusive breastfeeding. So skin to skin contact, it is given by early and continuous prolonged skin to skin contact. That is by placing the baby on mother's chest and by under her clothes, and there should be exclusive breastfeeding. So thereby promoting the lactation and facilitate the feeding interaction in this. So there are certain benefits with kangaroo mother care. So there will be benefits to the baby and there will be benefits to the mother. Let us discuss about benefits to the baby. So there will be increased breastfeeding with KMC. How? As baby is near to the mother, there is increased lactation reflex and there will be increased chances of breastfeeding. And one more good thing is there is a good thermal control, that is temperature maintenance. Ideally, the baby temperature should be around 36.5 degrees centigrade. By keeping the baby to the mother's chest, this risk of hypothermia, that is temperature below 36.5, this will not be happen. And there are more chances of early discharge. And there is a study, it shows like when the baby is with undergone kangaroo mother care, there is a high chances of discharge earlier compared to the conventional treated babies. And there is decreased morbidity, especially the apnea. What is apnea? Baby, especially preterm and low birth weight babies are undergo apnea, that is cessation of breathing for at least 20 seconds. As baby is stimulated by mother's respiration, this will be decreased and it will protect against nosocomial infections, that is hospital acquired infections. So KMC is associated with reduced incidence of severe illness like pneumonia during infancy. And what are the other benefits? This is for the mother. So mother are less stressed during the kangaroo mother care. How? As baby is with mother only, she will be in touch with baby and there will be good stronger bonding between the baby and the mother. And there is an increased confidence, that is satisfaction to the mother, as that is such a tiny small baby is with mother, she will handle that and she will have a good satisfaction like baby is good and I will give good care to her. This is a good benefit with kangaroo mother care. And one more thing, whom and when to start KMC? This is a good question. So any baby who is hemodynamically stable and who is eligible for KMC can be started as early as possible. There is certain criteria which I will discuss now. So if baby is birth weight is more than 1800 grams and baby is hemodynamically stable, it can be started as early as possible, even after birth. And if it is weight is between 200 to 1800 grams, if you can divide this into two categories: sick baby and stable baby. Sick baby, if baby is during the transport or in case delivery happened at primary or secondary care center, they can be shifted to tertiary care center like our hospital, and during transport also they can give KMC if at all baby is hemodynamically stable. Otherwise should be shifted earlier to the tertiary care, and should baby become hemodynamically stable and then we can start KMC. And if at all baby weight is less than 200 grams, the benefit most from the in utero transfer to the institutions with intensive care facilities. Here baby should be stable and after that it will take time, weeks to days to weeks. And once baby is stable, we can start KMC. So it can be initiated in a baby who is hemodynamically stable. Even baby is on IV fluids, orogastric feeds, oxygen, even on CPAP, we can start on KMC. So here is a picture showing mother is giving KMC and you can see the baby is having OG feed, tube feeding, and certain eligibility criteria. So who can give KMC? Eligibility of the mother. So mother, any mother, irrespective of age, education, religion, so can provide KMC, provided she should counsel about the benefits of KMC, how to give KMC. And here comes the medical professionals, health workers to counsel the mother and encourage the mother. We can explain them that the benefits of KMC to her and to the baby also. And she should receive adequate nutrient, diet and supplements. And she should be free from the serious illnesses. Why? Because if mother is at all suffering from some illness, she can't give, right? And mother should maintain good hygiene. That is the daily bath, change of clothes, everything should be under control. And family members should also be encouraged to provide KMC. Mother is unwell or mother taking rest. So father, grandfather, grandmother, anybody can give. And it can be given in resting position or during even sleep also they can give. So what is the procedure and duration? If at all we are to start KMC, prior to that there should be certain things we should discuss with mother. So what are the benefits with KMC and about we can discuss about it with our family members. Thereby they can give support to the mother. And which is involving KMC support groups. There are at all other mothers who is very preterm baby giving KMC. We can give counseling with those mothers who are giving KMC. It will be much more benefit to them. And what is the procedure? So here I am showing one picture. See. So here the baby is between the two breasts and head is turned to the one side like frog leg position and support from the baby's bottom with mother, or we can give anything. We can, right? The mother has to wear the front open dress like sari or blouse or gown as a culturally acceptable manner, and baby should be dressed here with front open sleeves, and there should be frocks with socks, mitten, cap, everything, nappy, everything, and baby should be placed between the mother breast and head should be turned to one side. Thereby they should take good airway opening will be there and allows eye to eye contact with the mother and her baby. And there the hips should be flexed and abducted in frog position. There is one more thing, the baby's abdomen should be at the level of mother epigastrium, and mother breathing will stimulate the baby, thereby preventing the apnea. So how to feed the baby in KMC? Mother should be explained about the breastfeeding when the baby is in KMC. She may express milk while the baby is in KMC. Or as baby is near to the breast, there will be stimulation for the milk production. And she can feed by orogastric feed or even palata. Depends on the condition of the baby, how much stable the baby and how is the feeding going on. And here comes our what all to monitor the baby and to the mother. Our nursing staff should monitor the baby carefully during the starting period of KMC. So what at all, we should monitor the temperature. We should touch the hands and feet of the baby as if they are warm or not, maintaining the temperature. And we should check the color of the baby. That is, baby has to be pink, and that implies the good circulation and the baby is hemodynamically stable. And the neck position, they should not be too flexed or too extended. Head position should be good position. It should not be extended or not should be too flexed. And we should check the breathing, check the airway to be clear. Is there any nose block is there? Breathing is regular or not? We should monitor clearly. And what is the question? Duration of the KMC. How many hours we can do KMC? So ideally should be initiated in NICU under the monitoring of the healthcare professionals, especially our sisters, should monitor. And once the mother, we can start period of session less than 1 hour to avoid as frequent handling and may be stressful to the baby. It should not be done less hours. I mean, less than 1 hour or less than 2 hours. It should be ideally given for at least 6 to 8 hours, and we can give even 24 hours a day, provided mother and baby should be comfortable and hemodynamically stable. Once the baby is hemodynamically stable and mother is confident, and we can shift the baby to the postnatal ward, and we should continue KMC in ward also. So there are certain criteria when to transfer the baby from NIC to ward. The baby should be hemodynamically stable. What is hemodynamically stable? Baby should be having maintaining adequate temperature. Good baby should be having good gaining weight, and mother is confident in taking care of the baby and providing KMC. And from that, when to discharge the baby from ward to the home. Here comes baby is well with no evidence of infection and accepting feeds predominantly with breast milk. Baby is having good weight gain, that is 15 to 20 grams per kg per day, at least for 3 consecutive days, and temperature is maintaining for 3 consecutive days, normal temperature, and with mother is confident in giving KMC to the baby even at home. So once the baby is good and mother is satisfactory and ready to take the baby to home, so we can discharge the baby, and that followed by we should follow up the baby till how many days, I mean how many months we should follow. Here comes this: once in a week till the post conceptional age of 37 to 40 weeks, or till baby weight reaches 2.5 kg to 3 kgs. Here comes every 1 week baby should attend to the OP and give consultation and should monitor at that time. And once in 2 weeks till 3 months of age, and once in 1 to 2 months till first year of age. These visits should be planned according to the baby weight. If at all baby weight is not good, that is 15 to 20 grams per kg per day up to 40 weeks, or if at all it is less than 10 grams per kg per day after post-conceptual age of 40 weeks, then visits should be infrequent, more times. And here comes the question: when to stop kangaroo mother care? So if at all the baby reaches the term gestation, that is 37 to 40 weeks, and baby having good weight gain, that is more than 2,500 grams, and baby is not comfortable with KMC because baby become big and she is not comfortable with KMC, wriggling out or pulls limbs out, even cries, that is the time should stop KMC and give adequate breastfeeding at that time. Yeah. Thank you.
So thank you so much for shedding light on kangaroo mother care. It is actually an insightful presentation. Thank you once again. Now I would like to introduce our next speaker, Dr. P. Vijay. He is a consultant neonatologist from Vizag. He has over 4 years of hands-on experience in treating extremely premature and sick neonates. He is also experienced in managing neonatal COVID and children with MIS. Sir, over to you.
అది గవర్నమెంట్ ఇందులో ఏమైనా యాక్సెప్ట్ చేయాలి. ఇందులోను ma'am, am I audible, ma'am? I'm also logging in.
Yes, doc, you are
Yes, sir,
audible.
you're audible.
Ma'am, just a moment. I'm having a small problem with this thing. Once I keep it ready, I just start.
Sure, sir, not an issue.
Your video, your voice is also clear.
The voice is not clear, ma'am.
Your voice is clear, your video is clear. You can go ahead with your presentation. Just share your screen.
Linked device.
Just a half an hour. Yeah, sure.
Phone చేస్తాను. ఫోన్ చేస్తాను మళ్ళీ ఫోన్ చేస్తాను. స్క్రీన్ షేర్ అవును ఇవన్నీ నో ప్రాబ్లం. తీసేయండి సార్ పెట్టండి.
Okay. Ma'am, just a final check. Are my slides visible and is my voice
Yes.
audible?
Yes, sir, yes, sir. Slides are visible.
Okay. A very good afternoon, everyone. This is Dr. Vijay Krishna from Visakhapatnam Medicover Women and Child Unit. I'm a consultant pediatrician and neonatologist. So today we are going to discuss about actually a very broader topic. It is respiratory distress in units. So in most of the babies getting admitted to the NICU, 30 to 40% constitute the babies which are getting admitted with respiratory distress. So this is, we usually see cases with respiratory distress in day-to-day life in the NICUs. So this is a very one common entity. So today I'm going to just try to brief it out because this is a very broad topic and there are multiple entities to be covered. So what is respiratory distress? So there are these are the components of respiratory distress. So the components are tachypnea, means the respiratory rate greater than 60 per minute, grunting, and this is the audible sound produced when the air is passing through partially closed glottis, and nasal flaring, chest retractions. So retractions can be intercostal retractions, sternal retractions, or subcostal retractions, and cyanosis. As you already know, it is the bluish discoloration of the skin. So when we come to the etiology, so what causes respiratory distress? So we can broadly classify it as two systems. I mean, two categories. So pulmonary causes and non-pulmonary causes. So pulmonary causes also, it can be still categorized into term babies and preterm babies. So firstly, I will just tell about preterm babies. So one commonality we see in preterm babies is RDS, that is the respiratory distress syndrome, which is previously called hyaline membrane disease. And in order of incidence, the next comes pneumonia and other things are pulmonary hemorrhage, air leak syndromes, and it goes on. So, and in the term babies, it has been listed as bronchopulmonary dysplasia. That is just a small error in the presentation. So that is the bronchopulmonary dysplasia is also one common entity which is seen in more preterm babies. So that is a chronic lung disease. When it comes to the term babies, so TTNB, transient tachypnea of newborn, which is a diagnosis of exclusion, this is commonly seen in the term babies. The other causes which follow by are pneumonia, aspiration syndromes like meconium aspiration, and air leak syndromes like pneumothorax, pneumomediastinum, and pulmonary hypoplasia and effusions and other airway abnormalities. So coming to the non-pulmonary causes, it will be constituting multiple systems. So different systems. It can be related to the dermal instability like hypothermia, hyperthermia, and cardiac causes like patent ductus arteriosus or any other duct-dependent lesions or any other cardiac diseases. And coming to the central nervous system, it can be birth asphyxia, any hemorrhage, intraventricular hemorrhage, and hematological causes like anemia, polycythemia. So other structural abnormalities like choanal atresia, TEF, mediastinal masses, vascular rings, congenital diaphragmatic area, and these all comes under the non-respiratory category. So, so how do you evaluate when it comes to the history wise? So these are the pointers. So when you look at the history, if the mother is having polyhydramnios, it is more of indicative of diaphragmatic hernia, esophageal atresia, and TF, other conditions like TEF. So, and when the mother is having severe oligohydramnios, it can lead to pulmonary hypoplasia. The other maternal risk factors, if they have, so if the mother is having chorioamnionitis, or if the mother is having any signs of infection like UTI or leaking per vaginum in the peripartum period, so that can be a risk factor for congenital pneumonia, or which is a presentation of early onset sepsis, which usually presents in the first 72 hours of life. So when there is an anticipated preterm, or when there is a history of preterm delivery in the mother in the previous pregnancy, and in the current pregnancy, preterm delivery is anticipated, and the antenatal steroids are not covered, and it can be a possible hyaline membrane disease, that is the RDS. So the other pointers are the meconium stained amniotic fluid. It can lead to aspiration of the meconium, which can lead to severe respiratory distress. And the last one is resuscitation at birth. So those babies which require resuscitation at birth due to the maternal causes or the fatal causes, so they can possibly be due to asphyxia and air leak syndromes like pneumothorax. So these are the entities. So these are the diagnoses based on the history. So based on the history, we'll arrive at a diagnosis. So coming to the onset of respiratory distress, at what time? So based on the time of onset of respiratory distress also, we can classify the diagnosis. So term babies, preterm babies. So term babies which are present, the respiratory distress is present from birth. So the causes can be TTNB, meconium aspiration, congenital pneumonia, and other developmental anomalies like any anomalies like congenital diaphragmatic hernia, choanal atresia, and it follows. The list goes on. And it comes to the preterm babies. So those with RDS, they usually present right from birth, and congenital pneumonia, as already discussed in the previous slide, that is early onset sepsis, they can also present right from birth. So other causes which are common, which are common both to term babies and preterm babies. Those are like pneumonia and heart diseases, metabolic problems like hypoglycemia, and developmental anomalies. These are the disorders which can present at a later period. So how do they present? So each disease present with a somewhat similar presentation with slight differences. So these are the clinical findings and the probable causes which we'll be discussing in this slide. So what is the common one? The most common is HMD and pneumonia. So they usually present from birth with respiratory distress and retractions. So what happens is, one important point you have to remember is, usually when there is the involvement of parenchyma, so parenchymal involvement is there, they present with retractions. Similarly, if it is a cardiac cause, retractions are less likely, and it is more like a quiet tachypnea. So that is one distinguishing feature between pulmonary causes and cardiac causes. See the second one, meconium aspiration. So in in conditions like meconium aspiration, so mostly meconium aspiration babies, they present in term babies or the post-term babies, post-maturity, they'll be presenting with meconium aspiration. So in those cases, the respiratory rates are usually very high. The rate of breathing, the rate of respiration will be very high, usually greater than 100, greater than 80 to 100. And one more thing is that the chest is also barrel shaped. That is one pointer towards meconium aspiration. And the next thing is that severe tachypnea with deep sighing respiration. So that is a pointer towards metabolic acidosis. That is in condition like asphyxia or shock, at any case in condition like IEM, which usually present in the later period. After period of normal duration, they usually present in the later part. That is inbornness of metabolism. And the next thing is tachypnea with coma and central jerky respiration. So whenever there is irregularity in breathing pattern, or when there is associated apneic episodes or jerky breathings, we should strongly consider the central nervous system abnormalities like birth asphyxia or any hemorrhage or any condition like IEMs. So when there is a heart disease, the child when the babies can present with quiet tachypnea. So as previous in the initial this thing I've already told. Next thing, so when there is reduced air entry on one side, so it can be discussed with two aspects, with mediational shift to the same side and mediational shift to the opposite side. So when there is a mediational shift to the same side, the probable cause can be lung collapse. When it is the mediational shift to the opposite side, we should consider conditions like air leak syndromes like pneumothorax, chylothorax, or any effusions. The stridor. So stridor usually is a presentation of upper airway abnormality, or the pathology lies in the upper airway. It can be in the larynx or any other upper airway. So other clinical findings are crepitations and rhonchi. Pneumonia can present with creps rhonchi along with respiratory distress. And crepitations can also be seen in chronic lung diseases, like chronic lung disease or the BPD. So one important point when you have respiratory distress is differentiation between the cardiac cause and the respiratory cause. So I told whenever there is parenchymal involvement, baby can have intercostal retractions. So when there is cardiac involvement, one presentation is quiet tachypnea. So the baby will be having more of tachypnea with lesser retractions. Retractions are comparatively less when compared to the pulmonary causes. So the pointers, these are the clinical pointers for cardiac causes of respiratory distress. So one is unexplained shock. So when a baby presents with shock, you have no obvious cause. There is no hypovolemia. There is no obvious cause for shock. You have to consider a cardiac cause. So signs of CCF, the child presents with hepatomegaly or tachycardia and cardiomegaly in the chest X-ray. So these are all the signs of CCF. Signs of congestion. So the baby may also have generalized edema. So bounding pulses in case of condition like PDA, patent ductus arteriosus. Absent femoral pulses like coarctation of aorta or any interrupted aortic arch. Next thing is precordial activity and epigastric pulsations, inappropriate tachycardia. So tachycardia which is unexplained. So tachycardia can be due to various causes. It can be in the initial stages of shock, it can be in hypothermia. So tachycardia can have multiple causes. So when you don't have a proper, when you don't have a proper cause for tachycardia and it is unexplained, so you have to consider cardiac causes also. So, and one more thing is that when a baby in the neonatal period, if presents with murmur, so you have to rule out cardiac anomalies definitely. So the last line is, and any baby with unexplained respiratory distress, especially when there is no setting for sepsis or systemic infections, any bacteremia, you have to investigate for cardiac cause with a functional echo. Okay. So this is one important aspect of respiratory distress, the differentiation between the cardiac and the respiratory cause. And one more important point I have forgotten to mention here is the hyperoxia test. So hyperoxia test is one thing where we'll be giving 100% FiO2. So we'll be giving 100% FiO2 to the baby, and then we'll check for the change in partial pressure of oxygen, that is PaO2 in the blood gas. So we'll have to look in the PaO2 in the blood gases. So if there is increase in the partial pressure of oxygen in the blood gas after providing 100% oxygen, so that can be possibly a pulmonary cause. So when there is a cardiac involvement, the partial pressure of oxygen usually will not change. Okay, so that is one differentiating point. So coming to the next slide, this slide looks much busy, but I can just tell you, or I can simplify this. So there are 4 categories here. So for the first thing is the pulmonary disorder, second thing is the cardiac, the third one is the CNS involvement, and fourth one is the metabolic disorders. So these are 4 groups. So what this slide explains is what symptoms will be present in which manner in all the 4 systems. So the components are tachypnea, retractions, grunting, cyanosis, hepatomegaly, displacement of the mediastinum, the findings of auscultation, stridor, seizures, and blood gas. And the last one is the effect of 100% oxygen on partial pressure of oxygen. The last one is the hyperoxia test, which I mentioned in the previous slide. So I told in the pulmonary disorders, we have more of parenchymal involvement, retractions. So tachypnea with retractions. So that is more prominent in the pulmonary disorders. And hyperoxia test, the last one, see, you can see this one, hyperoxia test. The PaO2 will be raised after giving 100% of water. So these are more towards pulmonary causes. The second thing is the cardiac cause. See, cardiac cause, intercostal retractions will not be there. I told retractions will not be there, or there will be minimum retractions. So here it is more towards tachypnea. And one thing, and one more important thing is CCF, congestive cardiac failure. So here you can have hepatomegaly. Hepatomegaly will be there, cyanosis will be there. Okay. And the next thing is murmur can also be present. So not that all cardiac cause will have murmur, but murmur can be present in most of the conditions. And see the last slide, that is important. The last one here, it is, there is no change in the partial pressure of oxygen when we give 100% of FiO2. This is one important point. So for the differentiation of cardiac and pulmonary causes, the next one is the CNS abnormalities. So CNS abnormality, so central cause presenting with respiratory distress. One important point is the breathing pattern will be jerky, or there can be irregular breathing patterns with apneic attacks. Possibility of apnea will also be there. So and other things and other components, seizures can be there. Seizures can be there. So this is one one thing which we can notice here. Seizures is one possibility. So more of irregular breathing, seizures. These are pointers of CNS involvement, central nervous system. And the last one is the metabolic acidosis. That is slightly a variable presentation. So it can present with simple tachypnea, and metabolic disorders also can present with seizures. For example, there is a case of hypoglycemia. So symptomatic hypoglycemia, baby can present with tachypnea and also seizures, though it is just mentioned as absent, but seizures is one possibility. So most of the other features are absent in the metabolic disorders. I think this busy slide was simplified a bit. So coming to the next one. So till now we have seen, so what is respiratory distress and what are the possible causes of respiratory distress. So we have a baby. So how do you assess respiratory distress? So we should have a scoring system. So scoring system, what is the advantage of scoring system is that we can assess properly. So we can assess the severity and we can also monitor. So if a baby is having respiratory distress, we made an intervention. We kept oxygen, we kept a CPAP, and after a few hours we can reassess with the same system. So that we'll get to know whether the baby is improving or baby is deteriorating, or whether we need to escalate the treatment. So two important systems will be there. One is Silverman-Anderson score, which is most commonly used in preterm babies, and the other is Downey's score. Downey's score is for the term babies, and this can also be used for the preterm babies also, but we commonly use for term babies. So this also I'll just go through the slide fast. So 5 components will be there. This the respiratory rate, cyanosis, air entry, retractions, and grunting. So the best score is 0 and the worst score is 2. Okay, so the small score is 0 and 2. So babies which are having a score of 4 to 7, so 4 to 7 or 5 to 7, we should consider CPAP. So we have to provide positive pressure ventilation, and those babies who are having score more than 7. Okay, so more than 7, we have to go for ventilation. See, I'll just give one example. See, 2 cases I'll tell. So first case, we'll take a stable case. For example, a baby is having a respiratory rate of around 55. Baby is no cyanosis, air entry is good, and with minimal retractions. Rate is 55 with minimal retractions, and there is no grunting. So here the score will be 0 for the respiratory rate, and all the cyanosis and air entry, it is 0 and 0, and here we are having mild retractions and there is also no grunting. So the babies, the score will be 1 to 2 if the rate increases. So 1 to 2. So that is less than 5. We should consider there is no intervention needed. And let's consider one more example. So baby is having more than 80 respiratory rate, and the baby is having cyanosis in room air, and air entry is not there at all, so barely audible, and severe retractions, and we also have audible grunting with naked ear. So here the score will be, so the respiratory rate it is 2, and cyanosis it is 1, 3, 4, 5 for the air entry, 6, 7, and almost 9. So if it is 9, so 8 to 9. So that is a very severe condition. So its score is more than 7, and we have to straight away go for ventilation based on the score. So though this is a clinical assessment only, we have to correlate with other findings like blood gas analysis or chest X-ray. Okay. So the next one is the Silverman-Anderson score. Similarly, we will have to give the scoring to the baby, and based on that, we'll do the intervention whatever is needed based on the severity. So Silverman-Anderson score 1. There can be a small confusion here in the assessment of Silverman-Anderson, upper chest retractions and lower chest retractions. So here we have to see upper chest retractions is this part of upper. So this will be termed as upper chest, and this will be called the lower chest. It is not that this half is upper and this half is lower. Once again, I'm repeating. Upper chest is this part, and lower chest will be this one. Okay. So this is the thing to be known here. So the components are upper chest, lower chest, xiphoid retractions, nares, that is nasal flaring, and the next one is grunting. So we have done the clinical assessment. Now, what all investigations are necessary for a baby with respiratory distress? So the first one is a bedside test. This is usually that is not so commonly done, but this is one test which is called the gastric aspirate. This is called a shake test. So what we do in the shake test is we'll take the gastric aspirate from the stomach of the baby, 0.5 ml, and 0.5 ml methyl alcohol will be taking. So 95% alcohol we have been taking 0.5 ml. So we'll be keeping in a test tube container with specified dimensions, and we'll have to shake it for 15 seconds and allow it to stand for 15 minutes. Okay, 0.5 ml, 0.5 ml, 15 seconds and 15 minutes. So when there is a rim of bubbles in the top, it is indicative that the baby has a risk of RDS. That's it. Okay. So if there is no bubbles formed, so it is indicative of lesser risk. So, but the problem with this test is that it is having only sensitivity of only 70%, and also in few studies it has been observed that the shake test is negative and baby is having respiratory RDS, and shake test is positive and babies are also not having RDS. So that's why it is having a limited use. Okay. And the next one is the transfugal elimination, that is to look for the air leak syndromes like pneumothorax. And next one, chest X-ray, most common imaging modality we use for the respiratory distress, and which is easily available in most of the centers. So the first one, the gastric aspirate test, where we use these actually, so where there is unavailability of a chest X-ray. So when there are limited settings, you can opt for gastric, the shake test. Okay, when you have a good amount of resources like chest X-ray, ultrasound, you need to resort to the other higher settings. So higher investigation. So chest X-ray, ultrasound. So ultrasound is also to look for effusions. If any effusions or any consolidations also, you can see, identify with the bedside ultrasound. Okay, and blood gas analysis. Blood gas analysis is one important aspect where you can identify the degree of hypoxia or hypercarbia. So whatever the blood gas status of the baby. Next things are the oxygen indices. So 3 oxygen indices are there: alveolar arterial gradient, diffusion gradient, and then arterial alveolar ratio and oxygenation index. So we cannot go deep into that. So we'll have to cover other aspects. So these are the oxygen indices to assess the degree of oxygenation for the baby. And other investigations we have to look for is the sepsis screen to rule out sepsis, and we have to do the blood cultures and blood sugars we have to check, serum electrolytes, and the next thing is echo to find out the cardiac to rule out the cardiac anomalies. So coming to the treatment, so treatment can be discussed under two heads. So one is the supportive care and other is the definitive care. So supportive care is that you have to provide a thermoneutral environment, you have to provide proper temperature of 36 to 36.5 thermoneutral environment. You have to maintain glucose homeostasis and calcium homeostasis. So normal blood sugar levels, normal calcium levels, and with a normal stable vitals like heart rate, respiratory rate, blood pressures, and saturation of oxygen. So pulse oximetry, one important aspect, and capillary refill time. So all these should be, these are all comes under the supportive care apart from the definitive care. So when you suspected case where there is sepsis or pneumonia, you need to opt for appropriate antibiotic based on the unit policy. And the next one is the monitoring, that is a part of supportive care, that is the RD scores, assessment scores, with the help of the two scores which is mentioned previously, that is Downey score and the Silverman-Anderson score. So next thing is the definitive treatment. What all we have to do for a baby with respiratory distress. So if it is a preterm baby, excuse me, if it is a preterm baby suspecting HMD, you need to go for a surfactant replacement therapy, either by the Inshu technique or whatever, by intubation and giving the surfactant. And surfactant can also surfactant also has role in other conditions like meconium aspiration, gestational diabetes, and pneumonias, and also pulmonary hemorrhage, where there is a surfactant dysfunction. So usually surfactant we have different from different sources. We have bovine origin, calf origin, and different brands we have. And surfactant, the usual dose is 100 to 200 milligram per kg. That is based on the phospholipid content. So that is regarding surfactant. So the next one is oxygen therapy. So oxygen therapy. So oxygen we should treat it as a drug, and in preterm babies we should give oxygen with proper caution, and we should set the SpO2 targets. See, for example, for a preterm baby, the SpO2 target should be some 87 to 92, and for term babies it should be 90 to 95. And in cases where there is other conditions, other associated conditions, so based on the baby's gestation, we'll have to titrate we'll have to keep the target saturation levels. So next modality is the continuous positive airway pressure, that is the CPAP or non-invasive positive pressure ventilation. So these two are the non-invasive ventilations. So nowadays, the trend is that people are tending more towards the intensivists or neonatologists. They're tending more towards the non-invasive ventilations, non-invasive ventilation, and particularly non-invasive positive pressure ventilation has a very good role, and it is helpful in preventing the babies from getting ventilated, and also the number of days on CPAP also getting reduced. Number of days which are requiring the ventilation are also getting reduced compared to the conventional methods. So here, so CPAP and NIV, it can be used as a step down care. That is, once you ventilate a baby, once you give a surfactant, and then post surfactant you can continue them on non-invasive positive pressure ventilation, so reducing the incidence of apneas and also further need for mechanical ventilation. So, and the next result is mechanical ventilation. So whenever there is a need for mechanical ventilation, you should go for mechanical ventilation. So one issue is that with mechanical ventilation is that you should be able to prevent the barotrauma. So proper ventilation with adequate support, that the previous one we have told, that is supportive care, additional supportive care, we have to do proper ventilation. So as and when we are ventilating a child, ventilating the baby, it depends on the cause of the baby. So you should be able to extubate the baby as and when possible to CPAP or NIV depending on the condition. Okay, so and mechanical ventilation is entirely a different topic, and it should be dealt separately. So and coming to the next part, so different entities are there. We can go deeply into each entity, but it takes a lot of time. So I'll just wind it off fast from here. So common entities in the term babies, TTNB. It is also known as the wet lung disease. Risk factors are term babies and cesarean section are the common risk factors. So clinical features, usually it present in the first 6 hours only. Respiratory rates are high. Usually TTNB doesn't require much of a higher respirator support. Usually it settles with oxygen, and very rarely it needs non-invasive ventilator support like CPAP. And it is a diagnosis of exclusion. And on X-ray, it will be having sunburst pattern or streaky perihilar densities. Okay. Next, meconium aspiration. Usually terms in term babies or post-term babies it will be presenting, and it can be mild, moderate, and severe based on the requirement of FiO2 and the degree of aspiration. So diffuse fluffy opacities will be seen. So these are the diffuse fluffy opacities, and so this is a case of very severe MAS. So and we can also notice the hyperinflation of the lungs in this X-ray. Next is HMD. So HMD, the X-ray findings can be of a different spectrum, so from a mild to mild, moderate, and severe. So prematurity is one important factor, risk factor for HMD. The baby presents immediately after birth can present with tachypnea and retractions and cyanosis. The natural course of HMD usually lasts for 72 hours. So this is a X-ray, so classical RDS, where the lung volume will be reduced and you'll be having a reticulogranular pattern. So that is the classical presentation in an X-ray for RDS. And the next X-ray, we can see the ground glass opacities. Okay, see, these are all the ground glass opacities we can see in the X-ray. And the next thing is very severe, with the severe RDS, where there is complete whiteout lungs. So this is the most severe presentation of RDS, and we can also see the air bronchograms in the X-rays. So the previous X-ray also we have an air bronchogram here. So air bronchograms will also be there in RDS. So air leak syndromes, that is pneumothorax, pneumomediastinum, and pneumopericardium. So pneumothorax, babies with pneumothorax, they deteriorate suddenly. So whenever a baby is on ventilator and there is a sudden deterioration, we have to look for pneumothorax. That is one important cause. So for sudden deterioration of a baby on ventilator. So pneumothorax you can diagnose with a chest X-ray and also with transillumination. So here is the air pocket, the translucency we can observe here. Okay, so there will be also a mediastinal shift to the opposite side. Next one is the pulmonary interstitial emphysema, and babies present within the first 48 hours with hypotension, bradycardia, and hypercarbia. So this can be seen in extremely preterm babies with RDS and sepsis. See, you can see two patterns. So one is the cyst-like pattern, and other is the linear pattern. So we can also see increased translucency, and we can also see a small bleb here, almost mimicking the pneumothorax. This is the pneumomediastinum. See here we can see this is the elevated thymus. Elevated thymus. This is called as Spinnaker sign. So this is a case of pneumomediastinum. It can also, pneumomediastinum is best seen on the lateral view of the X-ray. Next one is pneumopericardium. It presents with tachycardia and decreased pulse pressure. This is the X-ray of a pneumopericardium. So air under the inferior surface of the heart. And one more important aspect of respiratory distress in preterm babies is the bronchopulmonary dysplasia or the chronic lung disease. So, so for the preterm babies which are born very premature, that is extremely premature babies like less than 28 weeks, so babies will be requiring prolonged oxygen, and due to prolonged oxygen, babies will be having free radical injury and they'll end up in chronic lung disease, that is bronchopulmonary dysplasia. So these babies will have X-ray findings in the initial stages which will be similar to the RDS. So more of presentation will be like HMD only in the initial stages. Later on the X-ray changes will be different, and the haziness will be generalized haziness. That is in the second week, and cystic appearance will be seen in the further week, and later on there will be complete hyperinflation of the lungs. So these are the X-ray changes in the BPD. Next, pulmonary hypoplasia. Here, pulmonary hypoplasia, there will be complete pulmonary agencies. The lung. So here in this X-ray, there is a right lung hypoplasia. So the right lung is completely opaque, and heart will also be shifted towards the right hemithorax only. So there is we can also see the compensatory hyperinflation in the opposite lung. So congenital lobar emphysema. This is one somewhat rarer entity compared to the other conditions. So here, commonly involves the left upper lobe, and it is due to the intrinsic abnormality of the tracheobronchial tree. Congenital diaphragmatic hernia. This is a surgical cause of respiratory distress. So one important thing we have to mention here is bag and mask ventilation is contraindicated in a case of congenital diaphragmatic hernia. X-ray will be classical with the bowel. The bowel appearance will be the chest X-ray. See, you can see in the left hemithorax, you can see the bowel. Okay, so you will be hearing the gurgling sound on auscultation in a case of congenital diaphragmatic hernia. So in cases where congenital diaphragmatic hernia, if you suspect a congenital diaphragmatic hernia, you will have to directly intubate the baby if you need a respiratory support. And moreover, so with the advent of ultrasound, good ultrasound modalities now. So congenital defermentic hernia is being diagnosed in the antenatal period itself. So whenever there is a case of congenital defermentic hernia, delivery should be planned in a tertiary care center where there is proper access to ventilation and also pediatric surgery facilities. Okay. This is a classical X-ray of CDH and congenital pneumonia. So the risk factors for pneumonia are prematurity is a risk factor, and chorea amnionitis, mother having sepsis or UTI, and mother having leaking of membranes, or mother having fever during the peripartum period due to any cause. So common organisms involved in congenital pneumonia are the organisms which will present in the maternal genital tract, that is group B Streptococcus, E. coli, and Klebsiella. So clinical features, usually the baby presents early on the first day. Most of the babies present on the first day with respiratory distress, and others present by at least 12 hours of age. And one common feature we see apart from respiratory distress is the temperature instability. So you should watch for temperature instability whenever there is a whenever you suspect, whenever there is a possibility for congenital pneumonia or early onset sepsis. Okay, so temperature instability and also presentation of shock. So these are two common things you have to be much more aware, and you should be monitoring for those two things in the first 24 hours. And appropriate antibiotic therapy based on the unit policy. So this is a diffuse homogeneous infiltrates we can see, and here also the prominent interlobar fissure we can see in the X-ray. Okay. So almost we have come to the end of the presentation. So my take-home message is that respiratory distress babies can have varied presentation. So the clinical presentation can be it is related to the lung or the non-pulmonary causes. So coming to the etiology, so usually it depends on the gestation age of the baby, preterm baby or a term baby. So the cause can be different based on the preterm baby and term baby, and there are also few common entities like metabolic disorders, which will be common to both premature and term babies, and age of onset also is important. So there are separate entities which present from birth, and there are few entities which present after a period of normalcy. And next thing is you should have a proper targeted history. You should take a proper history. So we already, I have been discussed in the previous slides that so there will be pointers. There will be pointers for the history which will guide us towards certain diagnosis, and based on that we have to do a proper clinical examination, clinical assessment of severity. Thereby we can give a proper targeted treatment for the baby. So, and one most important aspect I have not discussed completely at all in the previous slides, that is the antenatal steroids. Antenatal steroids is one important aspect which can prevent the pulmonary morbidity. So apart from preventing RDs, it is also helpful in preventing NEC and also IVH. So preterm babies, whenever a preterm delivery is anticipated, so from 24 to 34 weeks of gestation age, antenatal steroid coverage is one important thing, and we always emphasize on our obstetric colleagues and obstetricians for the administration of antenatal steroids whenever there is an anticipated preterm delivery. So overall mortality will also come down when we administer antenatal steroids. Okay. So for the prevention of respiratory distress in particularly premature babies and pulmonary morbidity, we will have to give the antenatal steroids in all the mothers who are anticipated to have preterm deliveries. Next thing is that the respiratory therapy. So respiratory therapy is that the oxygen therapy, CPAP and NIV based on the severity of the baby. And apart from the definitive therapy, the supportive care is equally important. Thermoneutral environment, metabolic things like normoglycemia, normal calcium levels, and fluid and electrolyte balance, cardiac output, perfusion of the baby, proper maintenance of the blood pressure and perfusion of the baby, nutrition. So nutrition is also one important aspect, and strict asepsis. So all these supportive care should also be there apart from the definitive treatment you give to the baby based on the diagnosis. So CPAP and non-invasive ventilation, and lastly the invasive ventilation. So that completes my presentation. So if there are any doubts, you can ask. Sorry, unmute.
Sir, thank you so much for your insightful presentation. We look forward to have you again in our next series, sir.
Sure.
Yes, sir. Now the forum is open for Q&A. Questions can be posted at chat box, please. Please post your questions at chat box.
Hello.
Hello. Anybody has any questions? Okay, sir. Thank you so much.
Yes, yes. Happy to be part of this symposium. Thank you all.
It's a pleasure to have you at the symposium, sir. Sir, may I request you to please stop sharing your screen? I would like to introduce our next speaker, Mary Hensley. She is working as a nursing head in Medicover Oncology Unit, Hyderabad. She completed her master's in obstetrics. She has over 13 years of experience. Now she's presenting on News and News. Over to you, Mary.
Thank you, ma'am, for your warm welcome. And I should thank Swati, ma'am, for giving me this wonderful opportunity to be a presenter in this symposium. So the topic for today's presentation is PEWS and NEWS, Pediatric Early Warning Scoring System and Neonatal Early Warning Scoring System. The vital signs and the observations are the essential part of child's clinical status. Not only child, any adult also, the major essential part of observation, clinical observation is vital signs and constant observation. The pediatric early warning score and the neonatal early warning scoring system will give us the clue to identify the sick child before the deterioration occurs, so that we will be able to plan for the management if any deterioration occurs. And the observations recorded on the PEWS and NEWS score includes the respiratory rate, heart rate, blood pressure, oxygen saturation, temperature, level of consciousness, and capillary refill time. Apart from all these parameters, a non-physiological parameter which is scored in this is oxygen therapy. If the child is on oxygen also, we will be documenting in this scoring system. The standards and practice of this PEWS is we have to regular recording and assessment should be done. This will enable us to understand if the child's illness is very serious or is there any chance of any deterioration. This will help the healthcare professionals to identify the child's condition. If the observation triggers an increase in PEWS score above 0, again we have to inform to the respective primary consultant so that they will be coming and evaluating all the parameters for the child. And abnormal observations, if any, recorded by any healthcare support workers or any student nurses also, before informing to the primary consultant as a registered nurse, they have to cross-verify the scoring system and then should be informed to the consultant. PEWS score will act as a will not conformably act as a clinical judgment, but still based on the score we have to think in our side that the child's prognosis may become poor or the child may deteriorate. All these parameters we can assume, but in case if the child condition is deteriorating also, you can call the resuscitation team on the number 1500. Always we have to remember, if the child score falls above 1 or above in the PEWS chart, immediately as per the escalation guide, we have to inform to the duty doctor, maybe they will be informing to the respective consultant. And further investigations and interventions which is required should be carried out. And the third thing, reassessment also should be done periodically. This will enable us to understand whether the child's condition is there is any chances for improvement in the child's condition. And apart from that, the following parameters of palliative and end of life care children also, like the child's palliative diagnosis, past medical history, what is important in the child and family, then agreed ongoing treatment choices if the child's condition deteriorates, and if the agreed treatment of choices that may no longer be appropriate, like there is even the IV antibiotics, PICO admission also doesn't work out, and end of life care preferences. All this will give us what action plan we have to take for the if the child's condition deteriorates. And apart from this, any sepsis, the 6 steps of sepsis includes the high flow oxygen. Then we have to obtain the IV access and take blood and IV antibiotics. And we have to concentrate on fluid resuscitation, involve the senior clinicians early, and we have to start the inotropic support early. As long as we start, we will be in the safer side. So when the child is on high flow oxygen also, we have to constantly observe. This also, Pew scoring system will enable us to identify all these parameters. And neurological observations, ABPU scale, that is alert, verbal, pain, unresponsive. This is one of the simplest assessment tool which will enable us to assess the level of consciousness for all ages. If clinically any of these parameters like verbal, pain, unresponsive, any parameters differs, then automatically we have to start recording pediatric neurological observations and pediatric early warning scoring chart. And any deviations in the pain score also, like there are different types of pain assessment scale. Based on the pain scale, if the child's pain score is categorized between moderate to severe pain, again the pediatric early warning scoring system has to be initiated. So in this pediatric early warning signs, yes. So in this pediatric early warning signs, the scoring system includes 3 parameters: behavior, cardiovascular, and respiratory. The scoring system from 0 to 3. 0 to 3. From the behavior, if the child plays appropriately and sleeps comfortably, you have to give score 0. If the child is irritable, but you are able to console the baby, then you can give the scoring 1. And if the child is irritable, and you are unable to console the child, then you have to give score 2. And if the child is lethargic, confused, and reduced response to pain, then you have to give score 3. And cardiovascular, in that you have to see if the child's skin is pink and the capillary refill time is less than 1 to 2 seconds, then you have to give score 0. And if the child looks pale, if the capillary refill time is delayed to 3 seconds, then score 1 should be given. If the child looks gray in color, the capillary refill time is 4 seconds, or if the heart rate 20 or above or below the normal for that age group. Because in this column I have given for each age group what will be the average respiratory rate, what will be the average, the normal range for heart rate also. So based on this parameters, if 20 above or below from the normal age, then you have to give score 2. And if the child looks gray, mottled skin, and capillary refill time extends more than 4 seconds, and the heart rate 30 above or below normal for age, then you have to give score 3. Coming to the respiratory parameter, if the respiratory rate is within normal rate, no retraction, and the SpO2 is maintained between 98 to 100%, then the child is stable, you have to give score 0. If the respiratory rate is more than 10 above normal limits, or SpO2 is 97% on any oxygen device, or using accessory muscles for breathing, then you have to give score 1. And if the respiratory rate is more than 20 and 20 above normal limits, or SpO2 falls between 90 to 93, and if you can observe for retractions, then you have to give score 2. And if the respiratory rate is less than 5 below normal, or SpO2 less than 90% or retraction and grunting present, you have to give score 3. So, and this will be the scoring system. 0 to 3, it will be falling under green category. So no action is required. You can reassess the child and you can continue your observations. If the scoring system falls between 4 to 6, it will fall under yellow category. You have to inform the in-charge nurse or supervisor. Meanwhile, they will be informing to the resident and primary consultant. If the scoring system falls 7 and above, it comes in red category. Immediate call rapid response team, and you have to inform the physician or duty medical officer immediately. Any of these parameters, if a single 3 in any of this category, if you could find also, you have to inform to the consultant or the duty medical officer immediately to come and evaluate the child and give their findings. So based on this chart only, like each date, like today is the date you're starting at 7 AM. What will be the maximum score for each category? Behavior, cardiovascular and respiratory. How you are assessing and what will be the total score that you have to document. If any of the category differs, like any one of these 3 category, you are finding 3 scores also, you have to intimate to the consultant or duty medical officer immediately. And this is the neonatal early warning scoring chart. So in this again date, time is given. So up to the like today's date, at what time you are commencing this charting, from that temperature, it starts less than normal as well as the normal range and above normal range for all the parameters, temperature, respiratory rate, heart rate. All the documentation that falls under green category, all this temperature, respiratory rate and grunting you should not, it is not the normal thing, and heart rate and SpO2 and neurological observation. So all this category, when you are documenting, if it is falls under the 0 like a green column, then only observation is required. You can continue the observations. No interventions are required for the baby. If any one of this category, you are able to find out 1 observations in this amber color, again you have to inform to the respective consultant or the duty medical officer. You have to repeat the observations in another 30 minutes and you have to compare the previous recording. From that, how far it is differing. And 2 or more observations in amber color, again immediately you have to inform to the doctor or advanced nurse neonatal nurse practitioner for urgent medical review. Any one or more observations in red category, immediately you have to call for urgent medical review. So the observations for first 12 hours of age, you have to do first every hour. For first 2 hours you have to document, and further every 2 hours till next 12 hours you have to continue. And after 12 hours, if any observations are required, if any primary consultants or the duty medical officer or any other senior cross-referral consultants, anybody is insisting to document, then you can go for further documentation after 12 hours. The reasons for observations includes the premature rupture of membranes more than 18 hours and maternal group B streptococcal infection mother during the intrapartum period. If the antibiotics are not delivered for the mother, again you have to assess the newborn child after the delivery. And any mother who faced significant meconium strained or meconium aspiration syndrome then definitely you have to continue this new scoring. And any light meconium also, even meconium stained, not aspirated also, you have to keep the child under observations for 1 to 2 hours. If the child is stable, it is okay. If the child falls under this amber or red category, you have to notify the physician immediately. Apart from all these observations, any other reason for observations also you have to mention in this. Example, small for gestation, hypothermia, grunting, hypoglycemia, maternal pyrexia, then neonatal abstinence syndrome. So all these things you will be categorizing, and based on this, if the further observation is required, if the primary consultant is intimating you, then you have to further continue after 12 hours. Then apart from this, any child whom you are observing to be like lethargic, inactive, poor feeding, tachypnea or grunting, high or low temperature, floppiness, like they will be very soft with no proper shape and position. That is called floppiness. So all this category, and irritable child, the jaundice within 24 hours, any pathological jaundice you have identified, then pallor, duskiness. Duskiness will be like dark skinned child also, which you may not be able to identify. Even the normal color of the skin you will not be able to identify. So those parameters also you have to keep in your mind during your Pugh's charting. And apart from that, vomiting, abdominal distension, all these parameters you have to monitor this Pugh's and News charts. And based on the scoring system, this scoring system will enable us to early recognize the sick children before the deterioration occurs, before you are activating the resuscitation team. Based on the scoring system, you will be able to identify, you will be able to predict what is going to happen in future. This will enable us to think proactively and do certain measures to save the life of the child. Before concluding, I would like to bring the quote of a mourning mother. I never got to hear your cry. I never saw your beautiful eyes. I never touched your soft skin. I never saw your feet kick, but you are my angel and you will forever be missed. So this is a quote from a mourning mother. Please, as a healthcare professionals, if we proactively work together, we can save the life of the child. Thank you. I did.
Mary, thank you so much for shedding light on news and news. It is an outstanding presentation. Dear participants, it's time for lunch break. I kindly request you all to reassemble back at 1:45. Thank you. If anybody has doubts or questions, can be posted at chat box. All the questions will be answered after the session. Thank you. Good afternoon, one and all. Welcome back to the Neonatal Symposium. Now I would like to request our next speaker, Dr. Madhumohan Reddy. He completed his MS General Surgery from prestigious All India Institute of Medical Sciences in 1999, after which he successfully obtained MCH from Osmania University. He has over 18 years of experience. His expertise is in pediatric urology, pediatric laparoscopic surgery, and minimal invasive surgery. He has 6 publications to his credit and won many awards at various national and international conferences. Now he's presenting how to identify congenital anomalies in newborns. So,
good afternoon, one and all. I hope you had a nice lunch. A nice break was given by Dr. Sangeeta. And with that onset, I would like to start with an interesting topic, which routinely we see in a day-to-day life. But as for, I do know that, there are almost 1,000 people who have got registered in this workshop for today. So most of the times we have young generation of nursing staff, somebody who's on the senior line there. And for seniors, it will be a refreshing sort of thing. And for youngsters, it's an eye-opening thing. My topic for today is how to identify common external congenital anomalies in a newborn. Most of the times, we do see that the nurse accompanies a doctor, and sometimes you might be in a place where it might take some time for the doctor to come, and that is where the nurses play a very vital role in trying to identify these external congenital anomalies. Before that, if you want to identify a congenital anomaly, you should have a fair amount of idea about what is normal. I've given a small example. Like every time you see a child, none of us, are not bothered about the head circumference. In a normal newborn term child, the head circumference will be around 32 to 38 centimeters approximately. That is the range. Similarly, you have eye to ear measurements. You know the skin crease. If you know all these things, then you can go to the next step of trying to identify external anomalies. Why should you know all these things? This is a question which I would like to ask you. It becomes easier to identify anomalies at birth, then it has a very significant public health impact. That is the reason. If you miss at the newborn period, then you're going to pay a big price for that. From head to toe, I would like to take some salient points here, where with the photograph I have wanted to show you, such that you can remember these things very easily. When it comes to the head, the most common thing what you see is such type of head. It is called anencephaly. Now you may ask, what is anencephaly? Anencephaly is where the brain is not so well developed along with the skull. Though you have differences, various differences in head anomalies, anencephaly is seen 1 in 1 lakh. And this is a typical picture, as you can see now, where the skull is not so well developed. Along with that, the brain is also not so well developed. We have another anomaly called microcephaly. In other words, microcephaly, also called a small head. That is where I said the head circumference comes into the picture. Any child, any term child whose head circumference is less than 32 centimeters, you always have to consider microcephaly. Then you have a hydrocephalus, a big head. What is hydrocephalus? Hydro means water, cephalus means brain. So large amount of water which is got stagnant in the brain due to third ventricular obstruction. That means any child whose head circumference is more than 42 centimeters at newborn period, then you always have to consider it. So by a simple measurement of a head circumference, you can diagnose 3 diseases. So that is the importance of knowing the normal. And then you have another one called encephalocele. As you see, encephalocele, you have a protrusion of the brain contents, either anteriorly through the nose, that is where the defect is, or to the base of the skull, where the posteriorly. And on the top, you can see this is called anterior encephaly. Then onto the back, you can call it as posterior encephalocele, where the brain contents have herniated through one of the small defects. Once you finish the brain, then you come to the face. The most common thing what you straight away see is the defects on the lip and the palate. So if you see a one-sided defect on the lip, it's called unilateral cleft lip. You see on both the sides, it's called, sorry, 1 second. Yeah. See on both the sides, it's called bilateral cleft lip. And another defect you can see is a cleft palate. You can see here, it is just, you can see there are 2 pictures here. One is just an isolated cleft palate where there is a gap between on the hard palate. And then this is a cleft palate in continuation with a cleft lip. So there are 2. One is an isolated cleft palate. Another is a combination of cleft lip with cleft palate. In continuation with the face, if you come to the ears, you need to see whether there is ear or not. If you see ear, is it small one or no ear? If there is no ear, then it's called enotia. You can see here, there is no ear on this child. Microtia means the ear is developed, but not so well developed. So these are the 2 anomalies you see in the ear. Once you come down from the face and you come down into the chest, then you have 2 anomalies you have to see. Is it a normal chest? Is it a concave chest or a convex chest? You do see, as and now you keep looking at every baby which is born, especially the staff nurse, the young sisters who are posted in the, obstetrics, wing or into the neonatal wing. You need to have a practice daily, external examination is the core to any identifying the diagnosis of these babies. And then the most common thing for a surgeon is the anomalies in the abdomen. As you can see, the word I have written here is exampholus. See, exampholus is the protrusion of the contents through the umbilicus. As you can see here, there is a lot of intestines here, but they're all placed in a cover. So once they're all the contents which are supposed to be there in the belly have come out through the umbilicus, that means there is a defect in the umbilicus. All the intestines, most of the intestines have come out here. Now there are 2 subdivisions, exampholus major and minor. If the defect is less than 4 centimeters and it is only the intestines which have come out, then we put a diagnosis as exampholus minor. And when the part of the liver or a part of the spleen, or a part of the kidney is involved in this, then it is called exampholus major. I would like to say another diagnosis in the abdomen is called gastroschisis. You'll be wondering, the intestines are here outside. The previous film also had the intestines outside. Just have a good observation here. These intestines doesn't have a cover here. The umbilicus is onto the one side. The umbilicus is onto the one side. I hope you all have, try to see it. I'm putting a cursor onto that. The umbilicus is onto the one side. The defect is next to the umbilicus. Though the intestines all have come out, but it is not in a cover. It is not in the umbilical cord. So that's how you differentiate between an exomphalus to gastroschisis. Another one called hernia of the umbilical cord. And this is very, very important for nurses, especially when they put a clamp here. So you can see, I have put an arrow here to show you that, see, this is a part of the intestine. So whenever you want to put a clamp there, you need to milk the contents, especially, to the mother's side, to the baby's side, and then put a clamp. Always give a distance of at least, 3 to 4 centimeters, and then put a clamp there in case you see something like this. And in case by, disadvantageously you put some clamp like this, you can have a look here, the intestine is perforated and the contents are coming through this. So you need to be careful, especially for hernia of the umbilical cord. As you go down, in a child, especially in a male child, you can see these things in a newborn child, something called micropenis. There is another term called buried penis. You can see here, the penis is buried in this child. This is a normal scrotum. The penis is literally buried here. It's a normal penis, but smaller in size. Now, when do you call it as a micropenis? Most of you might have a doubt. If you don't have it, I'm just telling you that anything less than 2.5 centimeters of the length, take a measurement from the pubic tubercle. You see the middle picture here, the cursor is there. Take a measurement from the pubic tubercle to the tip of the penis. If it is less than 2 centimeters, then you can always say it safely as micropenis. If it is more than that, you can always say it as a buried penis also. In continuation with the genitalis, another defect which you routinely see is hypospadias. Hypo means below, the opening is below onto the ventral side. You can see here, the opening is onto the under surface of the penis. You can see an opening here. This is the pineal side, there is a urethra, you can see here. The opening is seen here. You can see in the below picture, the opening is into the underside of the penis. See all these films, the opening is into the. This is called hypospadias. If you see the opening onto the dorsal side, that is in this part. Now this is called ventral side, and this is called dorsal. If you see, it is called epispadias. Though I have not put a photo here, mainly not to confuse you people, but you need to identify this thing as hypospadias. Another thing, an interesting thing, though rarely you can see, is ambiguous genitalia, where you are not sure whether it's a male or a female. You can see something like this. It can be a clitoris or it is a small penis. You can see a good scrotum developed, but inside the scrotum, you won't palpate any testicles. So once again, it can be a hypospadias with bilateral undescended testis, or it can be ambiguous genitalia. That is where you coin the term ambiguous, because you're not sure about it. That means you need to do a proper workup on this child. First, get a genetic scanning done to confirm whether it's a male or a female. Then once you know it is male, then you have to get a proper scanning done to identify the testicles, or if the child has a hypospadias, then you might have to do a regular penile hypospadias correction. As you come down, the scrotum anomalies. The most common thing you see is a swelling in the scrotum. Now it can be many things. Either it can be a hydrocele, it can be a hernia, it can be a torsion testis. The most common things you see is a unilateral hydrocele or a bilateral hydrocele. You can see a swollen, scrotum here. Put a simple torch onto the base of the scrotum. See, you can see a testicle, a sort of a black thing and a whole trans-illuminate thing here. That's how anybody can do it. It's not just a doctor. You have a torch in the house, put a small pen torch. It's a pen torch. Something like a pen you have, so you call it as a pen torch. Put it to the base of the scrotum, you can see it clearly. For that to see, the area should be a dark room. That is the most important point here. If you want to identify this translucency, you should have a dark room. And then you can see a testicle here. You can see a beautiful vessels also here. So this is a classical congenital hydrocele. Another thing what you see is an empty scrotum, undescended testes. Is it unilateral or bilateral? So you can see in this picture, on the left side of the scrotum is well developed, but it's empty in nature. Onto the right side, you can see that the child is having a fullness here. As you feel it, palpate this child, the milk kit from the base of the scrotum. So the root of the scrotum to the base, you can feel a firm sort of a nodular thing. Then it is a testis. If you feel it emptiness, then it is undescended testis. These are few of the things. Though there are plenty of things to identify, but for somebody who is into day-to-day things, I think these are the things which are very important for you to identify it. You can save this picture. If you have any doubts, you can always be in touch with us. The department is always open 24/7. So please don't hesitate to know. If you have any queries, please let us know. We'll certainly answer you those doubts. The reason being that anomalies, the external anomalies, one cannot just miss this diagnosis. Thank you one and all for having a patient here. Have a good day. Bye.
So thank you so much for such an enlightening presentation. It is a great take-home message for all our team. Now the forum is open for Q&A session. I request all the participants to post their questions in the chat box. There is a question from one of the participants. Once again, explain about ambiguous genitalia.
Yeah, as I've said, see, ambiguous genitalia, you need to look into two things, whether this penis is developed or not, the scrotum is developed or not. The penis is not developed. Where is the opening? Especially in the case of hypospadias, a small sort of a penis, it can still be a clitoris also. So that is where you need to look into the scrotum now. Examine the scrotum properly. If you have both the scrotum is well developed and you have both the testes which are descended down, then you need not be afraid. But in cases where there is severe hypospadias or when there is congenital adrenal hyperplasia sort of patients, then you might have a varied presentation of hypospadias with bilateral and descended testis in male things. When you have such ambiguous genitalia, that is where you need to have. You keep looking at all the child. That's where I say to almost all the nursing staff who's posted in the obstetric side and the neonatal side also, keep seeing what you're seeing there. Then you will get a faint idea about how to distinguish. And if you have a hypospadia, small sized penis, and both the testicles have not descended, you can always straight away put a diagnosis of ambiguous genitalia and tell to your attending neonatologist or a pediatric surgeon to have a second look at it. Thank you. I hope I've cleared your doubts.
I hope it is clear. Now, I would like to introduce our next speaker, Dr. Neha. She works as a consultant neonatologist at Ashoka Medicover, Nasik. She's associated with Nasik Medicover since 3 years. Now she's presenting on hypothermia. Ma'am, over to you.
Thank you so much, ma'am. Good afternoon, everyone. Myself, Dr. Neha Mukhi, pediatrician, Ashoka Medicover Hospital, Nasik. Thank you so much, Reddy sir, for such an informative session. Now we'll start with next discussion topic, neonatal hypothermia. Today we are going to learn definition and prevalence of hypothermia, factors responsible for hypothermia, thermoregulation and grading, clinical features and management, and finally prevention and complications of hypothermia. Hypothermia is quite a significant problem. Mortality rate is twice in hypothermic babies. It is easily preventable condition, but it requires professional alertness of healthcare providers. To start with, we'll start the definition of hypothermia. According to WHO, hypothermia is defined as core body temperature less than 36.5 degrees Celsius. Normal axillary temperature is 36.3 to 37.2 degrees Celsius. Generally, in newborns, we generally record the axillary body temperature. This hypothermia is an underrated problem. As you see in the pie diagram, nearly 40% of the newborns admitted to NICU have hypothermia. Now, next we'll study factors which are responsible for hypothermia. First and foremost is that babies have large surface area per unit body weight because they have low muscle mass and high fat and water content. As you can see in the diagram, baby's head surface area is almost twice as compared to adult. So large amount of heat loss is from the head surface area. So priority, the head of the baby should be covered. Second is the decreased store of brown fat. What is brown fat? Brown fat is used by newborn to generate heat, which in turn helps to maintain the temperature. Newborns cannot shiver, so like adults. So this brown fat contributes them to generate heat. Brown fat accounts for 5% of the body weight, and it is seen in the upper area of the spine, shoulder, and adrenals. So nature has provided newborns with brown fat, which in turn helps them to generate heat. This brown fat is low in preterm and low birth weight baby, so they are more prone to hypothermia. Third is baby's skin is thinner as compared to the adults, as you can see in the diagram. So there is large amount of heat loss from the baby's skin. Fourth is the baby's water content of the body is almost 70%. So the large amount of heat is lost by evaporation. Other factors which add on are, first is low energy stores. Energy is required by newborn for heat production. But in newborn period, babies have low energy stores, so they require frequent feeding to generate energy, and which in turn required for generating heat. Their brain is immature to produce heat. High respiratory rate is accounts for the high insensible loss, which in turn indirectly contributes to the body's losing heat. Other factors which are responsible are, first is inadequate clothing, early bathing, baby exposed to the cold environment, premature babies, low birth weight babies, and if baby is having infection. So who says being a baby is easy? There are so many problems. Next, we will learn how the babies lose heat. First is conduction. There is heat loss to the contact of the when baby is in contact with the cold surface. Second is evaporation. There is heat loss from the baby's skin. Third is convection. There is heat loss due to air current or flow of air in the nature. Fourth is radiation. There is heat loss to any nearby cool surface like wall, floor, and window. Mechanism generally when baby is exposed to cold, if not managed at time, child develops hypoglycemia, hypoxia, and metabolic acidosis, which is a grave problem. Now we'll learn about grading of hypothermia. There are basically 3 grades. Now, as you can see, normal axillary baby temperature is 36.5 to 37.5. If temperature falls below 36.5, it is cold stress and it is a cause of concern. When temperature is between 32 to 36 degrees Celsius, it is called as moderate hypothermia and it needs to be attended immediately. And if the baby's axillary temperature falls below 32 degrees Celsius, it is classified as severe hypothermia and it is a grave problem and needs to be urgently attended. For practical convenience while practicing in NICU, a simple touch method with back of hand helps us to assess the cold injury. If the hands and feet of the baby are warm, it indicates that baby is in thermal comfort zone. If only peripheries are cold, it indicates that child is having cold stress. But if both peripheries and body both are cold, it indicates baby is in definite hypothermia. Now, next we'll learn how the baby is present, that is clinical features. If baby is having mild hypothermia, baby will be irritable, restless, cold extremities, and excessive crying may be seen. One may notice bluish discoloration of peripheries called as acrocyanosis. If not taken care, baby progresses to moderate hypothermia, in which child presents with difficulty in breathing, lethargy, not accepting feeds, heart rate abnormalities. There is delayed capillary refill time. Capillary refill time is assessed by pressing with a thumb on the sternum and for 5 seconds and then releasing the pressure, after which the time taken for color to return is recorded. If the time taken for refill is less than 3 seconds, it is normal. But if it is more than 3 seconds, it indicates delayed capillary refill time and the baby is having poor perfusion. Severe hypothermia, child presents with, it is a grave problem and child will be having breathing difficulty and severe skin problems like scleroderma. You can see in the picture, child is very sick and lethargic. Now next, we will see how we will manage if the baby presents with neonatal hypothermia. Mild hypothermia can be taken care easily if caught early. First and foremost, remove the baby from the source of cold area and shift the baby to the warm environment. Wrap the baby in weather appropriate clothes like caps, mittens, and socks, seeing that all parts of the baby are properly covered. Ensure skin-to-skin contact is given immediately either by breastfeeding or giving kangaroo mother care. Baby's axillary temperature should be monitored every half hour till baby reaches 36.5 degrees Celsius, and then baby should be monitored temperature as and when required. Watch for complications of hypothermia like apnea and hypoglycemia. Close follow-up of these babies should be done. If child is having moderate to severe hypothermia, baby should be removed from wet sheets and clothes, and rapid rewarming should be done by placing the baby in the incubator or preheat radiant warmer. Skin temperature should be always set 1 to 1.5 degrees Celsius higher than the body temperature of the baby. And as the baby's body temperature increases, accordingly the skin temperature should be increased. If the transport facility is absent and if there is absence of warmer, KMC should be used to normalize the baby temperature. Always you must assess the complications and look for emergency signs like poor sucking, irritable baby, difficulty in breathing, and blood investigation should be done to rule out sepsis. While discharging the baby, mother should be advised to how to keep the baby warm at home. If child is having any complications, prompt detection and management is essential. If baby is having hypoxia, oxygen support should be given. If baby is having poor perfusion and hypoglycemia, IV fluid support should be given. Blood investigation is necessary to rule out sepsis. As it is always said, prevention is better than cure. Now we'll learn how we can prevent neonatal hypothermia. WHO has set up certain guidelines called as warm chain, which is a set of procedures performed at birth as well as next few hours and days after birth to minimize the heat loss in all newborns. First is warm delivery room. Delivery room temperature should be set in 25 to 28 degrees Celsius. Second, warm resuscitation. While resuscitating the baby should be placed below the warmer using a pre-warmed linen sheets, warm hands, and warm humidified O2 support should be given. Immediately after birth, baby should be given skin-to-skin contact with the mother, and while the baby is with mother, it should be dried immediately. Priority head surface should be dried first. So next, breastfeeding. Early breastfeeding should be initiated at least half an hour within half an hour in normal delivery and within 4 hours in cesarean delivery, as breastfeeding initiates the emotional bonding with the baby. Weighing and bathing should be generally postponed. Weighing should be done once the baby is stabilized and given skin-to-skin contact. Weighing should be delayed till then. Bathing should be delayed minimum 24 hours after birth. While bathing, care should be taken that baby should not be taken in the running tap water. Instead, baby should be taken in a tub with warm water, with head well supported, and baby should be wrapped in a towel so that their heat loss is prevented. Baby should be appropriately clothed and blanket, with seeing that all parts of the baby are covered. In this image, this looks only good for photo shoot. Ideally, this is not the right method. Baby should be ideally covered, including head, extremities, seeing that baby is well covered with a cap, socks, and mittens. Mother and baby should be roomed in together all the time and should be kept close to mother. Mother should be encouraged to give breastfeeding and kangaroo mother care. In this picture, we can see the father can also give kangaroo mother care or any other member of the family. So it is well said, family that sleeps together grows together. For transportation, warm transport method for transporting the sick and preterm newborns, transport incubators should be used. Nowadays, we use embrace nets and plastic wraps, bubble wraps, and silver swaddler to transport the very low birth weight babies to the NICU. Last and the final, training and raising awareness of healthcare providers and family members should be done. They should be informed about how to place the baby warm, as hypothermia is preventable, but if early action is taken. Last, we'll learn about complications of neonatal hypothermia. First and foremost is intracranial hemorrhage, severe neurological injuries, eye injuries, pulmonary complications, and hospital-acquired infections. I hope all of you are better prepared to deal with hypothermic babies. Any queries? Thank you so much.
Thank you so much for such an enlightening presentation. Kindly post your queries at chat box, please. Thank you. Now, I would like to introduce our next speaker, Dr. Ramakoteshwar Rao. He is a consultant neonatologist and pediatrician working with Medicover Hospitals, Srikakulam. He has 8 years of experience. So, over to you. May I request Dr. Ramakoteshwar Rao garu to take over from here? Dear all, due to some technical glitches, Dr. Ramakoteshwar Rao will join us in a couple of minutes. Please bear with us. Thank you. I would like to introduce our next speaker, Dr. Ramakoteshwar Rao. He is a consultant pediatrician and neonatologist working with Medicover, Srikakulam. He has over 8 years of experience. Sir, over to you.
Okay, ma'am. Please share my PPT.
Sir, can you see the screen?
Yeah. Okay. So please enlarge the slide.
Sir, is this fine?
Yeah. Okay.
Thank you.
Thank you. Sorry, one moment, please. Hello, ma'am.
Your audio is not audible, sir. Your voice is not clear.
Okay.
Can you request your ID team to just help you? Audio is not clear.
Okay, ma'am. Okay. Just adjust that audio. Please share my PPT. Yeah, just back into first page, right? This is the third slide, I think. Am I audible? Hello? Hmm. Ma'am, hello?
Yes, sir, you can continue. You can go ahead with your presentation.
No, ma'am, just it running slide by slide. I don't want, so I just manually one by one.
Okay.
Start first slide.
Sir, but your presentation, you just come back by one. Yes, sir. Just give me a minute.
Okay, okay.
Go back. Yes. Yes, sir.
I mean, it is running. Hello, excuse me, ma'am.
Sir, we are able to do it. Yes, my IT person is working on it. Just give me a minute.
Okay.
Sir, are you able to see now?
Yes, ma'am. Yes, ma'am.
Yeah, you can go ahead, sir. We will share from here. You just tell me next slide, I'll run from here.
Okay, okay.
Your voice is not clear, sir. Can you able to talk little louder?
Okay, okay, I will adjust. Hello, ma'am. Am I audible right now? Hello.
A little better, sir.
Am I audible?
Sir, better. You can go ahead.
Okay, ma'am. Okay, thank you. Thank you. Yeah. Good afternoon to all. I am Dr. Ramkoteshwar Rao, consultant pediatrician, Medicover Hospital, Singapore. Next slide. Yeah. Today my topic was dope. Dope is a nothing but it is a mnemonic. When it was used, so acute deterioration of ventilator baby, suddenly decreasing the saturation and baby not doing good. So you identify the some problem in ventilator baby. So there is a one mnemonic dope. Dope means D for displacement of the tube, O for obstruction of ET tube, P for pneumothorax, E for equipment failure, right? So third slide, ma'am. Next slide, please. Yeah, okay. So coming to displacement of the tube. First, you look for the tube position, right? So how to identify the tube is in place or not? So first of all, you observe the breathing of the patient, and then any cough cuff displaced, cuff pressure is less or more. So you observe the cuff pressure also, and then so observe the auscultation of the chest. So is it equal breaths or unequal breaths? So first of all, you resolve that tube problem. So if displacement of the tube, maybe normally tube in trachea, but some conditions, some incidents occurred. So the tube was displaced to esophagus sometimes, or tube is pulled out from normal position. So you observe first that and put a ET tube newly, or to adjust the tube length from the lip to carina of the trachea. So that is the first one, is the displacement of the tube. Second one, if that problem is resolved, but baby was not maintaining saturations, so baby was deteriorated. So next one is you observe any obstruction of the tube, maybe secretions in the tube, or any blood or pus, sometimes foreign body lodge in the ET tube incidentally. Sometimes last option is kinking the tube. Sometimes some adult, pediatric babies more than 10-12 years, child maybe bite the tube. So you first suction the tube first, and then resolve the kinking of the tube. If tube is kinking, that problem is kinking of the tube. So resolve by the release the tube kinking. So that is the second one, obstruction of the tube. If obstruction is there, so baby SpO2 deteriorated. So you first introduce the suction catheter and then do suction. If problem was resolved and increase the saturation, it was the problem was obstruction of the tube. But if not resolving, but still deterioration of the patient and not improving the saturation after the suction, then suspect the third one is P for pneumothorax. Pneumothorax, simple pneumothorax or tension pneumothorax. Simple pneumothorax, how to identify? So sudden deterioration of the SpO2 and decrease the chest expansion and decrease the breath sounds on involved side of the pneumothorax. So how to resolve that problem? You just order the chest X-ray and do ultrasound of the chest. So diagnose the pneumothorax and put the simply ICD tube will resolve that pneumothorax. Second one is the tension pneumothorax. Sometimes above features plus sudden deterioration of the BP and decrease the heart rate also. So and on X-ray, involved trachea usually shifted away from the involved side, so towards the normal side on X-ray. Mediastinal shift is there. So we suspect pneumothorax and then do ICD tube in place will resolve the pneumothorax. And last one is E for equipment failure. Equipment failure may be either monitor problem or ventilator problem. So monitor problem, you observe the SpO2, heart rate, BP and respiratory rate. So first of all, you observe the ECG leads in place or not, and second one is the SpO2. SpO2 probe was properly fixed or not. So if SpO2 dropping, so first you observe the waveform of the SpO2 probe, SpO2 on the monitor. So wave is not correct. So you fix the pulse oximeter probe to the patient properly. If wave is correctly forming, so observe the patient. So if any above conditions are there, maybe displacement, obstruction, pneumothorax, or maybe sometimes monitor problem is also there. You just change the monitor and then check it for the problem. If remaining same problem, and then go to the equipment. Equipment means ventilator. Ventilator problem also there. So above features are all resolved. So baby not improving or child not improving saturation also. So you check for the equipment, ventilator. So you check for the O2 supply from the source to ventilator. tubing is any obstruction, ventilator tubing is obstruction. Second one, any leaking in ventilatory circuit, any leak, you observe the leaking of the ventilatory circuit. And power supply, sometimes power failure is also cause of the deterioration of the patient. You observe the power supply. And lastly, malfunction of the valves in bag or circuit. Sometimes valves are also malfunctioning. You check it and resolve the problem. Next slide, ma'am. Yeah. Recently, dopes and one S is added. S means stacked breaths. Stacked breaths observed in asthmatic patients. Asthmatic patients in ventilator and asthmatic patients, less respiratory rate, put in less respiratory rate. If incidentally or accidentally increased respiratory rate is in ventilator settings, so stacked breaths observed. So you stacked breaths observed. After that, you forcefully exhale the patient. How? Push down on the anti-chest wall with 2 hands until no further exhalation detected. Just squeeze the chest, pull the extra air from the chest. If deterioration continues, so check for the other causes. Next slide, ma'am. Yeah. General troubleshooting may be dope or something other causes. Any problem is there, you just fix the problem. Simple mnemonic dots. Dots means D for disconnect. First, if any saturation is going on deteriorated, so you first disconnect the patient from the ventilator. And over oxygen, give oxygen bag and mask ventilator by the manual. Feel for the, and at the same time, feel for the resistance of the lung, compliance of the lung. So before ambu bag, you should connect the 100% FiO2. So after that, you disconnect the ventilator, put ambu bag and do ambu bag with 100% FiO2. And then after T for tube position or function, you already told that if any displacement is there or any obstruction is there, just suction and suction the tube. And another T for tweak the ventilator. If that settings already put in the ventilator, is it correct for that age of the child or baby? You just check it for another time. If respiratory rate more, you slow down, you reduce the respiratory rate, increase the FiO2, increase the PAP. If less PAP is there, sudden deterioration of the saturation levels. So observe the settings of the ventilator parameters according to the age of the baby. And lastly, you do order the sonogram, ultrasound. Ultrasound to look for the any pneumothorax or displacement of the tube. If tube in esophagus, not maybe tube is not there in X-ray. So okay, it may be tube was the displaced we observed. So put another tube, right? Another next slide, ma'am. Yeah. Next slide, ma'am. So sisters in NICU, PICU, so don't ignore the alarm. You just hit the alarm and respond. See the problem, and if any parameters are altered or something, you just fix that problem. If you don't know, just ask the consultant and do the better. Next slide. So points to remember during ventilation, baby. So never ignore the alarm. Find out yourself what alarm is on and check the patient first. If the main point was the check the patient first. If any deterioration of the condition or SpO2 or any heart rate, you first observe. You don't observe the monitor or ventilator. You first observe the patient. Patient is breathing well or not. Patient is distressed or not. Patient is smooth, sedate or not. You first check the patient and then observe the monitor. If patient is problem or something distress is more, you and then observe the ventilator parameters. You resolve that problem and silence the alarm if not normally breathing going on, and never mute the alarm on regular basis. sometimes alarm is going on, running. So you just mute the, don't mute the alarm. So observe the problem and then check, fix the problem. Next slide, ma'am. And precautions before you reduce the troubleshooting during the ventilator. First, power is important. You either fix the correctly fix the power to the ventilator or not, and secure the power cord properly. Sometimes they loosely fix the power cord, and then sudden deterioration of the supply of the power. So you first fix the power cord properly, and then regularly check the battery backup. If power is off during the ventilator, so better to battery backup regularly, charging the battery regularly. Okay, next slide. First, is it working or not? First of all, ventilator patient was okay, and then check for the ventilator, is it working or not, and observe the pulse oximeter. And if any deterioration of the patient, dope was resolved, and then order the ABG chest X-ray to see the patient condition and any pneumothorax or displaced tube. Next slide. First, if any deterioration of the patient, foremost important is first disconnect the patient from the ventilator. Do ambu bag manually with 100% oxygen. So by doing the ambu bag, you observe the complaints of the lung. Next slide. Already told solution. If trouble is there during the ventilator of the patient, you just cuff pressure, observe the cuff pressure regularly, neither more nor the less. So you reinflate the cuff if less pressure is there, and any blood or secretions, just suction the tube, and then not improving, you just change the new UT tube, right? And tighten or replace the ventilator circuits or circuit junctions also. So mainly water trap is there in expiratory limb. Sometimes you just clear the water in ventilatory circuits, right? And the tube placement is observed. You sometimes pull out the tube during the crying and coughing, sometimes in wake child are not properly sedated. You check the tube placement also if baby is deteriorating. Okay, next slide. Next slide. Next slide. Okay, and lastly, some mnemonic small short is there. So in sudden deterioration of the patient, you observe the patient first, and next step was remove the patient from the ventilator and do ambu bag with 100% FiO2. If saturation is improving, so problem was the ventilator. So ventilator, you check for the ventilator parameters and ventilator circuit like that. If condition not improving, that is the problem in patient. You observe the patient first and do ambu bag continuously. And by the doing ambu bag, you observe the complaints of the lung. So if resistance is more while ambu bag, so you suspect QT2 block or secretions. You just suck the ET2 for secretions. If normal resistance while doing ambu bag, so patient troubleshooting was problem was maybe pneumothorax, normal resistance. You just put a ICD tube. If resistance is normal or less than normal, so you suspect cuff leak or extubated or tube is displaced. For that, you just re-intubate the patient. Next slide. So finally, I will tell first you observe if any deterioration while ventilator patient, you observe the first patient and then equipment. First patient is important. You observe the patient first and then equipment. So don't mute the alarm normally. So observe the any parameters alarming, any parameters, any problem in ventilator or equipment. Okay. Thank you, ma'am. Thank you.
Sir, it is a power-packed presentation. Thank you so much for your time and kind participation. Thank you. I would like to introduce our, so before moving on to the next presentation, Dr. Ramakoteshwara is ready to take up the questions. If anybody has any queries, please post their questions in the chat box. Please feel free to post your questions here. Thank you, sir.
Thank you.
Moving on to the last presentation of the day, I would like to introduce the next speaker, Dr. Rajesh. He is a consultant neonatologist working with Medicover Hospitals, Srikakulam. He is associated with Medicover since 3 years. Now he's presenting on NPR. Sir, over to you.
Dr. Rajesh, I would like.
May I request Dr. Rajesh to kindly take over?
Hello, good evening, everyone. Am I audible?
So you're clear. You may proceed.
Your presentation is on screen. We are able to see.
Okay.
You can go ahead.
Good evening, everyone. I am Dr. Rajesh. I'm consultant pediatrician and neonatologist at Medicover Srikakulam, and we are going to discuss today. Our program is neonatal resuscitation program. In shortcut, we are going to discuss about NRP. This is a comparatively big topic, but it's more of a practical rather than theoretical. We are going to discuss in a short way as early as possible. First, whenever good evening, everyone. Today we are discussing about the neonatal resuscitation program. Before attending a delivery, we should do an antenatal counseling regarding the complications, risk factors, is there any, or it is a absolutely normal delivery. And we are as a team in neonatal resuscitation program, teamwork is very important. And without the team support, we are not going to do individually in this NRP program. Before starting, we will go with this resuscitation. Every birth should be attended by at least one person who can perform a newborn initial steps of newborn resuscitation, like positioning the airway, providing warmth care, and positive pressure ventilation. Next, when perinatal risk factors are identified, a resuscitation team should be assigned and a team leader should be identified. Previously, we are telling that NRP is not an individual program, it's a teamwork, and we are going to do it as a team. The important 10 key behavioral skills regarding this NRPs, you should know your environment, and we should anticipate and plan according to the delivery. We have to assume that we have to in the team of NRP, we should assume the roles individually, and we should identify the leader, and we should give them the role of a leader, and we should communicate effectively what to do, what not to do, and we have to delegate workload optimally. We have to distribute the workload equally to all the team members in the team, and you have to use that attention very wisely. We have to use all the information whatever available, and we have to use all our resources what we have available. Whenever needed, you don't hesitate to call for any help, and you should maintain a professional behavior during the NRP program. What should we do before attending the delivery? We should do an antenatal counseling. What should we ask about the gynecologist regarding this? What is the gestational age? Regarding means whether it is a term delivery or a preterm delivery. If a delivery is going to happen more than 37 weeks of gestation, it is called as term delivery. When it is less than 37 weeks of gestation, it is a preterm delivery. We have to plan accordingly to the term gestation. And when the what is amniotic fluid? The amniotic fluid is nothing but the fluid in which the baby lies in the amniotic sac. Whether the amniotic fluid is clear or it is meconium state. If it is clear, we should anticipate a very normal postnatal outcome. When it is when the amniotic fluid is stained with meconium, we should ready for intubation, and it is required for intubation or suction. We have to plan anticipate accordingly. How many babies we are going to deliver? If it is a single term delivery, or we are going to receive 2 deliveries or 3 deliveries. We have to, and any additional risk factors. Risk factors like any if the mother is having any hypertension, diabetes, hypothyroidism, any PROM, any other risk factors, any drugs, medications in the antenatal history. We have to ask these 4 questions. Whenever we are going to attend a delivery, we should ask that these 4 questions like gestational age, whether the amniotic fluid is clear or meconium state, how many babies we are going to receive, whether it is a single term delivery or a twins or triplets, and any risk factors. We should ask for any risk factors like diabetes, hypertension, and team briefing. Team briefing means when we are attending a delivery, and we are going to ask the gynecologist regarding the 4 questions. She said that it's a 38 weeks of gestational age with clear amniotic fluid, and you should going to receive only 1 baby without any risk factors, without any additional risk factors. By this history, we can anticipate a normal neonatal outcome, which means the baby should not receive any intubations, the baby should not receive any positive pressure ventilations like this. If these 4 questions are very clear, then we can anticipate that it is going to be the outcome. The baby should be very fine. Whenever when for these 4 questions, if there is an the gestational is very preterm baby, or the clear amniotic fluid is meconium stain, and we are going to receive around 3 to 4 babies, 2 to 3 babies, or if the mother is having any additional risk factors like diabetes, hypertension, any seizures, eclampsia, like for these questions, if the mother is having any complications, means we are going to have any very difficult. The baby may require the resuscitation. If we will anticipate the resuscitation, and we assume that for the team members, we assume that what you have to do, and we should enroll each team member 1 role. Accordingly, we should plan the neonatal resuscitation. Equipment check. Before before using any equipment, we should check that whether it is there or not. If it is there, it is working properly or not. If it is working, means whether it is the fresh one, whether it is clean nicely or not. When the size is accordingly, we have to keep it or not. We should check all these equipment before. What is delayed cord clamping? In recent recommendations, NRP shows that we should, after the baby is born, we should delay the cord clamping for at least 30 to 60 seconds. 30 to 60 seconds. Because in both term and preterm infants, because there is a certain advantages with the delayed cord clamping, like lesser intraventricular hemorrhage, higher blood pressure and blood volume, lesser need for transfusion of the blood, and lesser NEC, necrotizing enterocolitis. Whereas if there is a slightly increased level of bilirubin, she should be more. Phototherapy is not usually a benign thing and which can be treated easily. Coming to delayed cord clamping, but there is if the baby is vigorous, we can do a delayed cord clamping around 30 to 60 seconds. If there is but if the baby is not vigorous, means the baby which not non-vigorous babies, means the babies which require resuscitation at the time of birth. We should not do a delayed cord clamping. We should do immediately cord clamping, and we can do a cord milking for infant born less than 29 weeks of gestation. Coming to the post-resuscitation care, yes, if the baby is born, the gestation is term gestation, and if the baby is breathing or crying, and good tone. For these three questions, if the answer is yes, the baby will stay with the mother, and we will do a routine postnatal care like providing warmth and clear the airway necessary, and we will drive, and we will assess for any congenital anomalies or congenital malformations. We will assess this postnatal care. Coming to the second level of post-resuscitation care, babies, for those babies with depressive breathing or activity, or those requiring any supplemental oxygen or ongoing nursing care, and those with high risk factors should be evaluated in ICU. For these babies, we should transfer to MSA, and we have to give a post-resuscitation care. This is the golden mean. The golden mean mark for completing the initial assessment steps is 60 seconds. Here you can see in these flow chart for the assessment of newborn. For the assessment of newborn, it takes roughly 1 minute. This is the golden minute. In these 1 minute, you have to assess the baby whether it is vigorous or non-vigorous baby. Vigorous baby means which is a baby having good tone, crying and breathing is nothing but a vigorous baby. Non-vigorous baby means for those baby with term gestation not having good tone or not breathing or crying. For these questions, three questions, if there is a answer is no, then we will change the scenario, which means we will warm and maintain the normal temperature, and we will position the airway, clear the secretions in the oral cavity if necessary, and then dry and we will stimulate the baby. After these steps, if the baby is recovered well, means we will go for ongoing evaluation and these means post-resuscitation care immediately. If after these questions also the baby is having apnea or gasping, heart rate below 1, we will initiate positive pressure ventilation. We will connect a SpO2 monitor, and we will consider ECG monitor also. These blue marking is nothing but blue changes in the NR. We will consider ECG monitor. If there is no apnea or no gasping and heart rate more than 100, then we will go for, if the baby is having labral breathing or persistent sinuses, we will go for position and clear the airway, and we will keep an SpO2 monitor. Supplementary oxygen is needed, and we will consider the CPAP. This is the golden minute, mark the completion of initial assessment and initial steps, reevaluating and beginning ventilation. If required, please retain to emphasize the importance of avoiding unnecessary delay in initiation of ventilation. Initiation of ventilation, which is the most important step for successful resuscitation of a newborn who will not respond to the initial step. The initial steps are like we discussed with in the previous in the slides, like provide warmth and maintain normal temperature during the resuscitation. You have to position the baby in morning sleeping position, like, and you have to clear the airway if any copious or obstructing the secretions. Dry thoroughly. You have to cover. You have to dry the head very thoroughly first, and then the body. If the baby is not having any vigorous activity, then we will do a tactile stimulation. We have to remove the bacteria which is removed, and we have to do the sleeping position. Temperature. Providing warmth is the first initial step. The temperature of the newborn of a non-asphyxiated baby should be around 36 to 35 degrees centigrade. The temperature should be recorded as bit of outcome and quality. To provide warmth, there are several methods, like variety of strategies are there. For preterm babies which are less than 22 weeks, 32 weeks of gestation, we should have a radiant warmer or plastic wrap. Along with radiant warmer, we have to cover the baby in a plastic wrap with a cap and the thermal mattress. Warm humidified gases can be used. By keeping the room temperature to 26, we can maintain the room warm surroundings. And the transport incubator. We should transfer the baby in a transport incubator from the delivery room to the nursery if it is born less than 32 weeks of gestation. All the gestation procedures, including incubation, chest compressions, and whatever we are requiring, should be performed in the temperature controlled environment. If there is a disordered settings to prevent hypothermia, we have to be a skin-to-skin contact, and you have to use the plastic wraps and placing the infant after drying the clean food-grade plastic bag up to the neck and to reduce mortality. Hyperthermia is nothing but the temperature greater than 30 degrees should be avoided because it introduces potential associated risk factors. Whenever a baby is delivered through mechanistic amniotic fluid and present with non-venous means baby is not breathing or crying with hypotonia and the heart rate less than 100, the infant should be present in using warmer, and we should initiate positive pressure ventilation should be needed. Routine intubation and the structural section, which is performed in previous recommended in previous NRPs, or not there in recent protocols. Appropriate interventions to support oxygenation and ventilation should be initiated as indicated by the individual infant. Whenever if the infant is born to become stained amniotic fluid, presence with poor tone and inadequate breathing efforts, the initial steps to be completed at the very moment, then you have to go for positive pressure ventilation. Positive pressure ventilation by bag and mask ventilation. Bag and mask should be initiated if the infant is not breathing or heart rate is less than 100% after initial step completed. Routine intubation for tracheal section in this setting is not resisted because there is insufficient evidence to continue the recommending this practice. Once the positive pressure ventilation is done, we have to evaluate whether it is effective or not by seeing the respiratory rate, respiratory efforts, heart rate, and oxygenation based on pulse oximeter. The heart rate, assessment of the heart rate. The assessment of the heart rate remains critical during the first minute of resuscitation and used by 3-lead ECG very recently. Because providers may not assess the heart rate accurately by auscultation, or palpation, and pulse oximetry may underestimate the heart rate. That's why you have to use 3-lead ECG in the place of pulse oximeter. After doing the initial resuscitation, if the heart rate is assessed, if the heart rate is less than 100, or if the newborn is apneic or gasping, give positive pressure ventilation. If the heart rate is more than 100, but spontaneous respirations and respiratory may be supported by continuous positive pressure rather than direct intubation and ventilation. Coming to the oxygen administration, in term infants, we have to resuscitate the baby with 21% FiO2, nothing but the room air. If blended oxygen is not available, resuscitation should be initiated there. Preterms which are less than 35 weeks of gestation should be initiated with low oxygen, nothing but 21 to 30%, and oxygen titrated according to the oxygen saturation levels. If the baby is breathing, oxygen administration, if the baby is breathing, but oxygen saturation is not within the target range, free flow oxygen may be given at 30% FiO2, adjust the flow rate to 10 liters per minute. By using the blender, we should adjust the oxygen concentration as needed. to achieve the oxygen saturation target. By free flow oxygen, we can give through mask of self-inflating bag, however, it may be given through tail of an open reservoir also. These are the targeted saturation set of the birth. If the baby is birth and at 1 minute, the targeted saturation is 60 to 65. In 2 minutes, second minute, it is 65 to 70. In third minute, 70 to 75. In fourth minute, 75 to 80. In fifth minute, 80 to 85. In 10 minutes, it is 85 to 95. What are the indications of positive pressure ventilation? Well, positive pressure ventilations and indications are apnea or gasping. If the heart rate is less than 100, even with strong respiratory, oxygen saturation cannot be maintained within target range despite of free flow oxygen for sleeper. How to give the positive pressure ventilation? Whenever you are giving a positive pressure ventilation, the mask should cover the mouth and cover the bridge of the nose. It should not over the chin or over the eyes. It should properly mask in the position of C and E, and we should hold the mask with the C and the 3 fingers around the jaw to make a tight seal. After making the tight seal, we should inflate the positive pressure ventilation at a recommended pressure of 20 to 25 centimeters of water. If required, we can give up to 30 to 40 centimeters. Whenever we are starting with PPV, start with oxygen concentration 21 for full-term babies and 30 for preterm babies. And we should begin a positive pressure ventilation at the rate of 40 to 60 per minute. After doing the 30 seconds of positive pressure ventilation, we should assess the heart rate. If there is increase in heart rate, your positive pressure ventilation is delivering effectively. If there is no increase in heart rate, then we should check for ventilation corrective steps like MR-SOPA. MR-SOPA is nothing but adjust the mask over the face, reposition of the airway, and the suctioning of the mouth and nose. Then open the jaw and lift the jaw. Open the mouth and lift the jaw. And we have to do an increase in pressure. And despite of all these pressures, if there is no increase in heart rate, we should go for alternative airway like tube and laryngeal mask air. Tracheal section. How do you do? If you are attempting to positive pressure ventilation, but the baby is not improving and the chest is not moving, despite performing all the ventilation corrective steps like MR-SOPA, including the ventilation, the trachea may be obstructed with secretions. Suctioning the trachea using a suction catheter inserted to the endotracheal tube or directly through the trachea with the Medicover aspirator. Highest priority in neonatal resuscitation program is effective ventilation. Effective ventilation by increasing the heart rate is the effective step in neonatal resuscitation. If despite of giving the effective positive pressure ventilation, if there is no increase in heart rate, then we have to go for chest compressions. And if the heart rate is less than 60 beats per minute, we have to go for chest compressions by inserting the thumb, by keeping the thumb over the lower 1/3 of the sternum, and the remaining finger should be encircling the baby chest, and we should compress anteroposteriorly. The depth of the compression should be 1/3 of the anteroposterior of the chest wall, and we should do a 90 compressions to 30 ventilations ratio. And we will do it by 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. Like this, we have to do a chest compressions and positive pressure ventilations. Whenever you are doing a chest compressions, you should increase keep the FiO2 at 100%. Adjust the FiO2 according to the pulse oximeter concentrations. Whenever you are going to begin chest compressions, you should go for ventilation. Whenever the baby is non-vigorous, you should go for IV cannula placement. Umbilical vein catheter is very easy and we can do it in the bedside only. Despite effective ventilation and effective intubation of effective chest compression, there is no increase in heart rate, then we have to go for IV epinephrine, nothing but eternal. Epinephrine is indicated when the heart rate remains less than 60 after 30 seconds of ventilation, and another dose of 60 seconds of coordinated compressions and ventilations. After that, you can give for epinephrine. when to stop resuscitation. In general, there is no new data that you have to stop when to stop resuscitation. If the upper is 0 at 10 minutes, it's a strong predictor of mortality and mortality in preterms and terminals. But the decision will change according to individuals.
Thank you so much. Thank you so much for your informative session. We thank you all for being present here today in such informative and insightful sessions. On behalf of our team, I would like to call up Ms. Martina to extend the oath of thanks to all our participants and consultants. Thank you. Good evening to the honorable doctors and all the dignitaries assembled here. Gratitude is the best medicine. It heals your mind, your body, and your spirit, and attracts more things to be grateful for. Wherever the arts of medicine is love, there is also a love of humanity, says Hippocrates. It is we are learning to have a love for humanity. On behalf of the entire institute, I would like to thank the honorable resource person who have enlightened us with their invaluable contributions. I'm sure all of you agree with me that the knowledge we have got from this webinar help us to render our services in a better way. Thank you very much, admirable doctors, for your enlightening talks. Once you stop learning, you start dying, says Albert Einstein, the great scientist. It is indeed a great thing that someone is very interested in our learning to make us alive in our professions. It is none other than our program director, Dr. Sarath Reddy, the director of Medicover Hospitals. We are here for a reason, and it must be effective. That is made by him today. So on behalf of our institute, I sincerely express my gratitude to him. Thank you very much, sir. Everybody is genius. But if you judge a fish by its ability to climb a tree, it will live its whole life believing that it is stupid. They have contributed a lot, making plans for what we need exactly for our ability and helping our institute grow. Dr. Rakesh Prabhu, Chief Medical Officer of Medicover Hospitals, and Dr. Sangeeta, Medical Superintendent of Medicover Women and Child Hospitals, Ms. Bhavani, Medical Women and Child, Nursing Superintendent of Medical Women and Child Hospitals. So earnestly thank you for all your assisting to make this day valuable. The capacity to learn is a gift. The ability to learn is a skill. The willingness to learn is a choice, says Brain Herbert. She creates in us a willingness to learn. That is the reason we are updating and equipping ourselves in our field. I thank Madam Mrs. Swati ma'am, the group head of nursing. Thank you, ma'am. Participation, I think, is one of the best medicine to educating, says Tom Glazer. Last but not the least, I thank all the participants for actually participating, saying, I shall participate, I shall contribute, and in so doing, I will be gainer. I'm sure you have achieved a lot today, and you have made this program lovely and successful. Let us start practicing what we have learned today through this program. Thank you one and all, and keep moving for the best.
Thank you, Ms. Martina. Last but not least, anyhow, vote of thanks has been shared by Ms. Martina. And I would like to thank from bottom of my heart, Dr. Sharath Reddy sir, who is our new visionary kingdom of the education academic active participant. I would like to extend my heart of bottom of my heart to sir, and Dr. Rakesh, our CMO group medical officer, and Ms. Sangeeta. Today's entire session shared by her as a moderator, and she extended her support with truly inspired moderating with extensive support for this program. And I would like to thank all my nursing heads, whoever been work hard to make this program successfully. And today these symposiums will not stop you, and it will be on hands-on training. All the doctors, whoever panelist has been given very good eyesight and very good valuable informations to practice on hands-on trainings, and the sessions will go on, and we will not stop these lectures. It will be helpful for every nurse. It's a big take-home messages has been shared, and these programs are recorded, and we would like to share for all the nursing heads to continue these kind of nursing sessions and participate actively and involve your academics so strongly, making by your education department. So I would like to thank all the participants once again, very patient listening, and still we are here to ask you. Chat box is open, or you can share in your emails, or you can share your questionnaires through your nursing heads. If someone is not, feel free to ask with the doctors. We are here to answer you, either not today or tomorrow, anytime we are ready to open forum. So I would like to extend my sincere thanks to all nurses for patient listening, and we will keep on moving for this kind of academic session. It should be a hands-on training. It's not only PPT sharing, you all should know how to do on hands-on training. It should be on best evidence-based practice. Thank you all once again for patient listening. Thank you.